I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name is Jeremy Buckingham and I am the chair of the committee. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. To each witness, welcome and thank you for making the time to give evidence. We very much appreciate it. Starting with Professor Martin, could each witness please state your name and position title and swear either an oath or affirmation? Professor.
Okay. Thank you very much. Hello, I'm Jennifer Martin. I'm a clinical pharmacologist and a physician. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Mr. Battye?
Correct, yeah. So my name's Bruce Battye. I'm the Director of Pharmaceutical Operations in the Ministry of Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. Dr. Vazquez?
I'm Santiago Vazquez, Operations Director, Forensic and Environmental Toxicology at the Forensic and Analytical Science Service in Sydney. And the evidence I am about to give, I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Thank you. Would any of you like to make an opening statement or have any introductory remarks?
Yeah, thank you. I'll do that.
Thank you, Professor.
Thank you very much. I'd like to open just with a very simple statement, which is about the complexity of this plant, cannabis, and the drug product that we actually get from this plant. There are issues around whether this is a plant versus a drug, and some of the issues around the way we extract it and provide it to patients are quite different to how we use other drugs. There's some real complexity around the analytical aspects of measurement of the drugs in the body for this drug, but the analyte that we're measuring is the same whether it's medically prescribed or recreational. There's some complexity around the regulatory pathway for prescription of what's called a TGO 93 product, which is a product that has been approved on a very baseline set of conditions, such as how much of the heavy metals will be able to be tolerated in a human, such as how much pesticide or microbe on the plant is tolerated versus an actual registered therapeutic on the ARTG. And we do have two medical cannabis products that are listed on the ARTG. It's a complicated drug because it has a number of drug interactions, and those interactions are particularly with drugs that people that take cannabis take. And you can see that by looking at the TGA website. Almost all, or a significant proportion of those scripts are written for people with chronic pain and anxiety. And those conditions are often co-prescribed a number of drugs such as opioids, antidepressants and other therapies which interact not just with the behaviour of the cannabis product in the body, but also the effect on the brain actually of having multiple drugs that actually affect the same organ. It's an area where there's a lot of contaminants and additives, and particularly a person who actually takes these products regularly might actually not know how the products they're taking from time to time are comparable. I think there's an issue with replicability, and that's why the ARTG listed products are actually much easier for us in terms of using them from a clinical perspective. These, particularly if they're only TGO 93 approved, they might differ in batch and in time, and even a script that a patient has in their cupboard. The products may well be different over the period of usage for that particular patient. And there may be a difference between the amount of acid or drug or metabolite that's actually in a patient's batch. And we actually don't know much about what that might look like for an individual product at a point in time or a particular patient. The last point we just wanted to make is that I guess as physicians and in health, we really focus on the safety of that person and the person that we're prescribing that product for. However, some of the safety that we have around the use of drugs generally we don't necessarily have for the cannabis products. And this is because for this particular drug, this drug only can be prescribed by doctors who are not the patient's usual doctor, who may not be interacting with that patient's mental health team, with the other doctors that the patient sees for their other conditions. When that patient gets side effects from a prescribed TGO 93 product, the person that prescribed, or often it's actually not a person, it's actually this person has been able to obtain it over the web and not interacted necessarily with a doctor. As practitioners, we can't actually find the person or a person that's responsible for the script and to know why that drug was prescribed. The person themselves is often quite, they feel unwell, and because they may not have told their GP that they're actually sourcing this product outside, they don't necessarily want to go to the GP. And if I get a call like that, or my colleagues, we actually advise the patient to come to hospital if they're not feeling well. So we wanted to really make the point that this product is complex to use and there are much greater effects on the person and the health system than actually a standard prescription of a standard drug. Thank you.
Thank you. We'll start with some questions from the opposition. Do you have any, Mrs. Carter?
Yeah, thank you all for being here today. If I could start with you, perhaps, Professor Martin. If I understand what you just said, and forgive me, I'm not a scientist, there is a more complex issue if we were to regulate or cannabis because of drug interactions and because people would be taking commonly a number of different drugs. In what are the consequences of those drug interactions? And I'm thinking, I guess, with everyday activities, with ability to work, with ability to drive a car, that type of thing.
Thank you. So there's two types of interactions that we're seeing quite commonly. Firstly, some of the cannabis products stop the breakdown of normal drugs in the body. So drugs are broken down in the liver or in other organs. This particular one in the liver. But the cannabis products can stop the breakdown systems in the liver. So that means that other drugs that are usually broken down in the liver, like antidepressants, their levels become very high. So the side effects of those antidepressants are much more prevalent. And some of those antidepressants might have a side effect of being sedated, for example. But in addition, those drugs all work on the brain. And so there's an additive effect on some of those side effects, such as confusion, such as sedation or sleepiness.
So if somebody was on, let's say, cholesterol medication or blood pressure medication and they were prescribed cannabis, would the cannabis interact and stop the effectiveness of the blood pressure drugs, for example?
It's more likely to lead to higher levels of those drugs, so you might get more of an antihypertensive effect or more of a cholesterol lowering effect. Okay. Those classes of drugs are typically broken down in the body usually by different pathways, but the antidepressant drugs and some of the opioids are the ones we're most concerned about because they are dependent on systems in the liver that break down drugs into inactive compounds.
Okay. Yeah. And did I understand you to say that there are two types of medicinal cannabis that are subject to more regulation and therefore higher reliability in terms of what is actually contained in the product, and that would be the desired framework if cannabis was to be more freely available in the community?
Well, from a health perspective, we prefer drugs to be listed on the ARTG because that's the list of drugs that our regulator has ensured have proper manufacturing work done, that the batches are the same between the batches, that we actually have safety data, and not just a population, but across all of the populations that are likely to be using the drug. And they also have efficacy data and particularly information on different doses and different responses. So all of that information has to be provided for the TGA to say this drug is safe and effective for Australians. We do have two cannabis products that have met that threshold. One is for the paediatric epilepsy, some types of that, and another is for spasticity and multiple sclerosis. But the rest of the products to be prescribed under the special access scheme are approved by what's called a TGO order, which is a minimum base of safety. It's not about efficacy, so it's saying you basically have to meet these thresholds of how much heavy metal or microbe or pesticide is in your product before people can actually, before it's deemed appropriate to be available.
So if I can maybe translate that in a way that I can understand, the TGO standard is like a food safety thing, making sure that there are no contaminants in milk, for example, whereas an ART standard is about being able to, with some degree of certainty, be able to understand side effects, drug interactions and clinical safety for a person.
Yes, it's a much higher regulatory level.
Yeah.
The TGO order, and I know you've got a TGA specialist coming later, but it's not that there's no heavy metals in it. It's basically saying this is the acceptable level of 4 heavy metals, including arsenic, cadmium, etc., that would be tolerable under this order. Yep.
And can you give us some information about the potential effects associated with regular use of cannabis on driving, for example?
Well, there's a lot of literature out there. I'm not going to go through all the literature today, but certainly it's well known that THC, which is one of the 2 main components that we've seen in a lot of the products that are available in Australia, does affect a lot of your reaction time, your ability to respond to external stimulus, your coordination, etc. The cannabidiol appears to have less effect on that, and I think there's certainly been quite a difference in the regulation that's been applied in New South Wales around safety to drive with cannabidiol versus the THC. However, cannabidiol does make you sleepy. People do use it to help them sleep. So certainly for a doctor talking to a patient about using cannabidiol, even though it might not be necessarily as illegal, it's still often recommended that people taking cannabidiol shouldn't drive because it actually might make them feel sleepy, particularly if they're taking other medications or they're some other way affected by a medical condition that might make their ability to drive less safe.
Okay. Yeah. And are there any studies which have demonstrated any causal links between cannabis legalisation and increased rates of mental health disorders such as psychosis or schizophrenia?
I think I'll take that on notice. There's certainly a lot of anecdotal reports from practitioners in the area that they feel they've been seeing more of this, that there's been more ED presentations, and I certainly another college, the College of Psychiatrists, have actually been in the media talking about the increased psychosis from the recent increase in availability of cannabis products. But in terms of the actual details, I would have to get that to
if you could take that on notice, I'd be very grateful. Yeah. Perhaps, Mr. Battye, if I could ask you about challenges in regulating the quality and potency of cannabis products, because I think Professor Martin has outlined the different the challenges with that. So if it were to be regulated, can it be done? What would we need to do to ensure standardisation?
Yeah, the New South Wales Health does not regulate the quality of the products. That's the TGA area.
Right.
So
Yep.
the TGA, their jurisdiction is the quality of the products. So those which meet the standards of safety, quality, efficacy, they're the ones that they assess, which end up on the Australian Register of Therapeutic Goods. What Professor Martin was referring to there was 2GO93, which is, again, that's a therapeutic goods order administered by the 2GA, and in that case, it's they're not assessed for quality, safety, efficacy by the 2GA. What they look at is contaminants and things like mould and that sort of thing, and that's about it.
How do the regulatory frameworks interact? Because if, for example, New South Wales was to legalise cannabis, but other states had not, but we're relying on the TGA for those standards, how do those frameworks interact?
So the TGA regulates the product. That's all they do. When it comes to supply, through the whole supply chain, whether it's from wholesaler to pharmacy, dispensing, prescribing, labelling, storage, all those sort of things, they're all under state and territory regulation. So that's the cut-off, that's where the line is. 2GA regulates product, and in the case of non-AR2G products, the access to the product, getting through the border. But once it gets to the distribution or the supply chain, that's state and territory regulation in all states and territories. Yeah.
Okay, right. Thank you. Given that medicinal cannabis is already legal, do you foresee any regulatory challenges in differentiating medicinal from recreational products if legalisation were to occur?
You asking me?
Yeah, sorry,
okay.
yes.
Yeah. So our area is really just the medicinal cannabis. So 2GA have another role, and that is the scheduling of medicines and poisons. And back in 2016, delegate of the 2GA made the decision to put medicinal cannabis into Schedule 8 of the poison schedule. So that then, following on from that, all the states and territories then regulate that product as a Schedule 8 product. And so a Schedule 8 product are substances which should be available for use but require restriction of manufacture, supply, distribution, possession and use to reduce abuse, misuse and physical or psychological dependence. That's the definition that they apply. And so as a regulator in New South Wales, what we're looking at is the licensing of wholesalers for Schedule 8 medicines, the supply to pharmacies, the prescribing by medical practitioners or nurse practitioners, and that's our remit.
Just in terms of the prescribing, perhaps a question to the whole panel, the issue that Professor Martin flagged, that the person prescribing the medicinal cannabis may not be the regular treating doctor. How is it that comes about? Why have we got different people prescribing medicinal cannabis rather than the person who is responsible for the monitoring the whole of the person's health?
Thank you.
I'll go first. Look, what's happened is since medicinal cannabis to become available, 2017 onwards, there has been the growth of third-party telehealth clinics spring up all over Australia, and the reality is a lot of this medicinal cannabis is actually being prescribed via this telehealth model. And that telehealth model, so they're operated by third parties generally. They employ doctors or nurse practitioners as their prescribers. They could be located in the Northern Territory, South Australia, they could be anywhere. The patients see these clinics, and there's hundreds of them online, and they go directly to those clinics just to get one product only, which is the medicinal cannabis. So those clinics are set up not to provide whole of health care for the patient, but to supply one product only. Whereas the same patient may very well have a GP, which they see for their blood pressure or asthma or what have you. Yeah.
But given the risks of drug interactions that we've heard, should there be more regulation around these one-off prescription factories that you've just described?
Yes, there probably does need to be, but unfortunately, if you look at the legislation that applies, they're outside our reach. Our jurisdiction is over the medical practitioners, the nurse practitioners, the pharmacists, the nurses, but anyone can open up a clinic, and quite often, even in the suburbs, your GP might be operating out of a clinic which is owned by a company who could be anyone. Yeah.
Did you have a comment, Professor Martin?
I was just going to say, from from a physician perspective, managing people that come in with, for example, psychosis. I know I didn't have the numbers to give you, but for example, and there is some thought that people that have dementia, sometimes their children think that their sleep will be improved by prescribing a cannabis product. Now, the GP may not want to prescribe that for the patient because they may know, for example, that earlier in life they did have a psychotic episode with recreational cannabis, or that they've got all these other medical reasons that they don't want to prescribe cannabis. But it is possible to actually then still be able to go outside the normal care model and get cannabis. When the patient comes to hospital, the family often doesn't want the GP to know that their relative has been prescribed cannabis, and it's actually quite difficult and complicated, I think, from a medical practitioner perspective. We do like transparency and good discussion and data collection between people looking after a person. We think that that's how you get the best health, but those communication systems are built up between the GP and their specialists and the community providers in the hospital. So when there's someone else that comes in and prescribes something else that's a one-off, for a start, that person may not know all of their history, and certainly the other doctors may not know that this person has been given a cannabis product. So it does make the care quite difficult and quite challenging. And I think when I was referring to before the psychiatrists, they've actually been quite public in talking about this and the presentations that they're seeing. So I think it's a concern from a health perspective. Yes.
So it sounds as if the way in which it's medicinal cannabis is currently being prescribed and made available actually compounds health risks for patients.
From my perspective and my colleagues, we would say that it certainly is not putting, it's making it very difficult to manage that patient's care.
And are there any suggestions you have for how that could be addressed?
Well, some of the problem, or not the problem, but I see one of the issues being that although we can prescribe, or doctors can prescribe, we tend to not, because the evidence isn't actually all of that helpful, particularly in a comparative setting. So we do have ARTG listed products that we know work for sleep. We know they might work for other conditions, and we have a lot of safety data and a lot of usage data across different populations, so we feel very comfortable with using those drugs. We don't feel comfortable with using a drug that doesn't have that efficacy data, even if this might be something that the patient is requesting. So I think certainly people, if they feel they would like to try something else, another plant material, and we do have psychedelics and other therapies. People like to try those things to see if that will make them feel better, but it's certainly not something that a medical practitioner may feel that warrants a prescription based on the lack of efficacy and the concerns around safety. So they'll go elsewhere to get what they need.
Okay, thank you. Dr. Vazquez, if I could come to you, what are the current capabilities and limitations of forensic toxicology in detecting cannabis impairment, especially perhaps in the context of road safety or operating machinery at work?
It's really difficult from a lab perspective to determine whether someone's impaired or not. From a lab perspective, what we're doing is we're just objectively measuring concentrations of THC, whether that be in oral fluid or blood or urine, and potentially other matrices depending on the situation. But we don't really actually comment as a lab on the level of impairment. We provide those data to Police Pharmacology Unit, and they make that assessment on the basis of the drug we see. For example, it might be THC, and there might be other drugs on board as well. So they look at the totality of the situation and see if there's any sort of drugs that have a summative effect or additive effect and may cause impairment.
So alcohol, it's a 0.05, 0.08. Is there a similar scale for THC impairment?
No, not that I'm aware of, although internationally there are various cut-offs that may be used for the level of a drug in blood, for example. And it has to be in blood because that's indicative of something that's circulating in the body and may have that sort of pharmacological effect. In some countries it's around 2 nanograms per mil. In other countries it's 5 nanograms per mil. So, but there's no literature that I've seen that, you can have a threshold level of 0.05 that, is indicative of impairment.
And is THC impairment similar to alcohol impairment in that we're told 2 standard drinks for women, 3 standard drinks for men? Does body size and gender, do those things affect THC impairment?
Look, it's an area that's outside of my area of expertise because I'm not a pharmacologist, but there are a lot of factors that need to be considered. Weight, metabolism, frequency of use, amount or level of dose given, concentration in that particular preparation. Possibly a question best answered by Professor Martin.
Happy for anybody to jump in on these questions. Yeah.
Okay. If we're talking about blood measurement, so blood measurement, that's we do have a reasonable understanding of the relationship between how much is in the blood and how the brain is affected. But you're correct in that short-term use versus long-term use can actually affect that relationship, and that's because the drug distributes around all of the fat in the body if you used it long-term. So that relationship actually becomes less clear. So the other issue we have is just if people, lose weight, for example, and the drug's been stored in the fat, then we might see release of that into the blood as well and impairment. And we know that happens when people have had an anaesthetic, that actually they might be quite good straight after an anaesthetic, but then as the fatty drug, which is the same as the cannabis drug, then leaches out of the brain or other fat depots into the blood, people then feel quite sleepy. And it's why that we recommend often there's a period of not operating machinery or not driving a car after you've been exposed to any drug that actually can sit in a lipid store for a period of time, because you actually don't have a clear knowledge of the half-life or the time taken to clear that drug actually from the body.
Okay, and in terms of the time taken to clear the drug from the body, and I'm thinking about THC impairment, so we've got a rough understanding of how long after you've been drinking before you should drive without risk of being an impaired driver on the road. Do we have that data for THC?
Well, we do have that data for the general population having a certain amount at a certain time. The problem we've got is that you don't really know how much will be in the body for some of the TGO 93 approved products, because they're not standardised products. And again, as I said earlier, that actually you might be taking a different amount of the drug by the time you're getting to the end of your bottle of drugs. So I think it's that complexity that makes this drug very, very difficult to use clinically, and why as practitioners we prefer to use the ARTG product, because we know how that drug responds, we know the relationship between the dose and effect on the body, and how long it takes to clear that drug from the body. Yeah.
So, Professor, you just said you do have the data in that regards.
For those ARTG products?
No, you were saying at a societal wide, we do know how long it does take for your body to sort of clear the drug.
That's correct, for a population, but not for an individual, because that would depend on what other drugs they've been taking, whether they're taking other drugs that might prevent the breakdown of these products, and whether there's been additives added to some of the TGO products that patients are taking. So that's where the complexity is, not with the ARTG products. We know how to use those very well.
Yes, but in terms of the data with the non-ARTG, could you provide that on notice?
Sure.
Okay,
thank you.
I might just jump in and ask a couple of questions. So, what oversight does New South Wales PSU have regarding New South Wales doctors who decide to prescribe medicinal cannabis?
So in New South Wales, we receive a lot of intelligence, notifications that come to us around about 2,000 odd a year, which includes also lost and stolen drugs as well. And quite often we get that intelligence from other prescribers, pharmacists, and sometimes from patients as well. So we have that sort of information. We also have SafeScript New South Wales. SafeScript New South Wales is a monitoring system which is available to medical practitioners, nurse practitioners, pharmacists to look into what the patient has had prescribed for them for the monitored medicines list, which includes all the Schedule 8 drugs, It doesn't include all Schedule 4 drugs, but it includes some Schedule 4 Appendix D drugs as well. So by monitoring that SafeScript New South Wales, we can actually pick up a lot of aberrant prescribing, excessive prescribing, dangerous prescribing, that sort of thing.
How many medical practitioners in New South Wales are prescribing medicinal cannabis?
Yeah, I don't know the answer to that.
So we don't have, it's not compulsory for a doctor to inform New South Wales Health that they've decided to prescribe a particular medicine or medicinal cannabis?
No.
Okay. So we don't know how many medicinal cannabis practitioners are.
If I could just explain a little bit further to assist the committee. What we do see is we see what's actually dispensed. And the reason for that is that every Schedule 8 drug in New South Wales and other drugs on the monitored medicines list automatically go into SafeScript New South Wales. With a prescriber in New South Wales, whether they wish to take up a SafeScript and enrol in the SafeScript New South Wales program, that's up to them. It's not compulsory for them in New South Wales. But what we do see, we see what's coming out at the pharmacy end, which includes not only those who are prescribing in New South Wales, but they could also be, using the telehealth model, they could be prescribing for patients in other jurisdictions, and we wouldn't know about that. So we pick up those which are dispensed in New South Wales, and we can relate that to the prescribers in New South Wales or the prescribers interstate as well.
So in that way, you do know who's prescribing medicinal cannabis
For those
that are on the safe.
that's right. It pick up on the database.
And
correct.
how many people are outside that, in your opinion, outside that framework?
Look, I wouldn't know. I suspect there would be some, but I wouldn't know the number. Yeah.
And those doctors are prescribing all kinds of different Why don't we have a compulsory system so that we know who's prescribing what?
Look, the decision with SafeScript New South Wales was to make it non-mandatory for prescribers. At the time it was introduced, my recollection is that COVID was still an issue for prescribers and also for pharmacists. And I remember at the same time we also had a lot of floods in northern New South Wales. So when SafeScript New South Wales was launched, that was in the background of the thinking that these people who we rely upon, our doctors and our pharmacists to provide medicines, they're already under a lot of stress in the circumstances.
Well, I know, but we're not in COVID now, so why wouldn't we have a compulsory system so that we can assess if there's safe prescribing of all medicines?
For all medicines?
Yeah, well, yeah.
Yeah, well that...
Well,
that's
well, it'll say Schedule 8 medicines then.
Schedule 8 medicines, yeah. Look, that's a policy decision that the government would have to make. But I can only speak the way it is at the present time. I might add that in some other jurisdictions where it is mandatory for prescribers to use a prescription monitoring system, there has been issues of compliance, and there's been issues like, for example, some specialists, they hardly ever prescribe. A cardiologist, for example, might be just writing out the odd script here and now. And for those people, that means they'd have to take up software and go into all of that. So there's that sort of consideration which other jurisdictions have found has been an issue from time to time.
Professor, you said that there's anecdotal evidence that people are presenting at EDs with psychosis or negative interactions with other drugs. How come we're not collecting that data? And what sort of numbers are we talking about here? Is it a massive, because medicinal cannabis prescriptions have increased across New South Wales into the hundreds of thousands of patients. What sort of numbers are we looking at?
Okay, I can't give you an exact answer on the numbers, but certainly through some work done by the ABC, the psychiatrists have been very public about the number of presentations with psychosis. But I can get that number to you. I think for many, particularly in a public health system, it's a matter of dealing with the patient who's unwell in front of you and dealing with those issues. There certainly have been concerns in the emergency department over people presenting with something called hyperemesis, which is vomiting that can't be stopped, and that's from the high potency THC. And these are often young people that sit in the emergency department, often for up to 24 hours taking a bed because they need to be there because they're sick and they can't take any fluids down, and a number of medications, including off-label medications, we may have to use to actually control that vomiting. And as a pharmacologist, I do get called about some of those. For example, even the use of a derivative of a capsicum called capsaicin to actually rub on the abdomen to stop people vomiting. So these are things that we might have seen irregularly in the past from people that had an addiction issue with cannabis. But we're now certainly, anecdotally, seeing across the board, not just young people presenting with such I mean, these are really high potency products, the TGO 93, some of them are greater than 98% THC. It's quite different to some of the recreational use that might have been seen 20 years ago. So I think we're seeing high potency products, we're seeing presentations with psychosis, hyperemesis.
What do you mean when you said across the board?
In multiple different specialties. So I guess I'm speaking as a physician, not a surgeon or a psychiatrist. And so a lot of these problems for medicines used to come into just medicine, to general medicine or geriatrics. But now these are other practitioners in the ED in mental health that are seeing additional presentations with safety concerns around the use of some of these therapies, and in particular from a pharmacology perspective, I know that these are very high potency medicines, and perhaps my colleague Bruce might like to speak on that fact of the potency, but it's quite different to say 10 or 15 years ago when as a practitioner you would see people that did smoke recreationally a few joints or cones, and they would come in with a particular presentation. This is on another level. This are people that we cannot control their vomiting because of high potency THC.
But how many people are we talking about? Like, because there's hundreds of thousands. Are we talking about this being like dozens and dozens of people a day, or what sort of numbers?
I can't give you those numbers, but I will take that on notice. But certainly there has been an increase, and practitioners are talking about this, and there are people that have written manuscripts about this issue. And certainly it was enough for the psychiatrists to talk to the media about the concerns they had with managing these products in the hospital setting.
When there are red flags about prescribing patterns in New South Wales, especially with telehealth, how does the PSU deal with that? And what are the red flags? What are you seeing in terms of practices that may cause you concern, and how do you respond?
So, if I go back and sort of give a little bit of context, Mr. Chair.
Please do.
2023 is when we realised through SafeScript New South Wales, I should explain, was rolled out across New South Wales, throughout the whole of New South Wales in May 22. And it was during 2023 we noticed for the first time what appeared to us to be excessive volumes of Schedule 8 medicinal cannabis products. And I should clarify what I actually said before about the scheduling with the TGA. At the time, there's also the CBD product cannabidiol is actually Schedule 4, but only at 98%. So it's very specific, and there are some non-ARTG CBD products which are allowed also to be prescribed in Australia. So what we actually picked up is excessive, what appeared to us quite excessive prescribing, and the things we're looking at is actually the volumes going through, being dispensed at particular pharmacies, and we also noticed that some of the patients were getting various opioids, psychostimulants, antidepressants, antipsychotics, benzodiazepines simultaneously. We noticed that some of the patients were also current on the opioid treatment program in New South Wales, so they were also getting methadone, and that would generally be a different doctor. We found, like some of the examples I can give you, like a patient prescribed 75 different medicinal cannabis medicines. We found over an 8.5 month period, a medical practitioner issued medicinal cannabis prescriptions which enabled a patient to receive 2,392 medicinal cannabis medicines at a cost of $348,000. We saw another example was, again, over an 8.5 month period, we saw a medical practitioner who had issued medicinal cannabis prescriptions to a couple who were residing at the same address in New South Wales, and that couple received 3,590 units of medicinal cannabis at a cost of about $519,000, and that was all dispensed at the one pharmacy.
What tools do you have in your regulatory toolbox to deal with? What's the response when you see something like that happen?
So what happens is we analyse that sort of data, and then from that we have to decide on how we're going to address that. So an investigation plan would be drawn up, and the first point of call would be the pharmacy who's dispensing all that, and we get all the data out of there. We look at the prescriptions. We also look at their storage at the same time, and from there we'll work out who the prescribers are, and we'll address each of the prescribers as I said, some of them from interstate. So some of them are outside of our reach, and initially most of them that we were looking at were outside of our reach at interstate.
So if they are outside of your reach, is there anything you can do about it?
Yeah, so what we actually have done is that we can't investigate them. They're registered at their main place of practice is in another jurisdiction, so we refer them to AHPRA, Australian Health Practitioner Regulation Agency, and that's the process we go through with that.
Is it symptomatic of a problem the industry, the prescribing has across the board, or is that an anomaly, is an aberration? Do you think it's a problem across the cannabis prescribing regime generally?
Look, there is a lot of concern about the prescribing of medicinal cannabis. As I said to you, we started off having a look in 2023. Early 2024, AHPRA actually convened a meeting in Melbourne, which included AHPRA themselves, the Medical Board of Australia, Pharmacy Board of Australia, TGA, and all the state and territory
So when did
regulators.
you say that was, Mr. Batt, 2023?
Sorry?
When did you say that was?
That was that's February 2024.
Yeah, okay.
Yeah.
So last year,
Now,
yep.
at that meeting, there was presentations by Victoria Health, and they had a PowerPoint presentation on the investigations they'd undertaken, and it showed exactly the same things we were seeing. TGA, AHPRA, they all had presentations, and everyone expressed they're all seeing the same sort of evidence that I'm talking about, Australia-wide. And coming out of that meeting, there's a communique issued the end of February from all the participants, which said, we've got to work together, we've got a problem here. And so, this is not a small-time issue. It's something which is apparent across Australia, and all the regulators at different levels all recognise that this is an issue.
So what have you done subsequent to that?
Well, in New South Wales, we then commenced further investigations, and virtually the whole of 2024. As a result of that, we counselled some nurse practitioners, pharmacists, but then we also took regulatory action against some nurse practitioners, medical practitioners and pharmacists.
Do you think it's possible that the problem with the medicinal cannabis prescription regime is that some patients are accessing it for like adult use recreational cannabis?
Based upon, as I just explained there, a couple of examples I gave you, I would think it was almost impossible for those people to be utilising the amount of medicinal cannabis which they were receiving. So the assumption is that they must be on supplying to other people. The other...
that's one issue, like on supplying, but is it possible that people are accessing medicinal cannabis saying, I've got back pain or anxiety, when they're really just looking for recreational cannabis?
Look, I think that is possible for sure. Yeah, I haven't seen any papers, or I think the Australian Institute of Health and Welfare recently did a survey of users of cannabis, but I couldn't comment on that.
Okay, thanks. Do you guys got good?
Thanks,
Yep.
Yeah, thanks all for this along. It's really appreciated and helpful. Just firstly, for Professor Martin, if I could, are you able to tell us how developed compared to other areas of research is the research on this interaction between cannabis and other medications? Is it an under-researched area, or is it pretty well understood?
It's actually very well understood by the international pharmacology community. There's publications in American, European, British, as well as Australian journals, and it's well known and well understood.
Yeah.
We did set up a statewide service to support practitioners using medicinal cannabis when the regulations changed, because we knew that there'd be patients that wanted their doctors to prescribe that, and that was certainly in the evidence or the information and the guidance that we gave to practitioners. And we have written documentation as well. It's on the New South Wales Health website, and we provided that to practitioners who are prescribing it for the first time, to ensure that we could enable them to do it as safely as possible.
Yeah. So is it important that people accessing medicinal cannabis through these doctors, that they get advice on the interactions with other medications?
Absolutely, and that was back to my original comment on the fact that the GP is the person that manages the patient's holistic care. They do send them out to the old subspecialist or specialist here and there, but the problem is that the GP is the font of all knowledge in terms of knowing what the patient what's happened to them in the past and the other drugs that they're on. So whenever that doctor will start a medication, they'll be checking for interactions and asking the patient to drop the dose of another therapy, for example.
Yeah.
And just following on again from that, the toxicity of drugs is often well known by a patient's GP, so they'll know when they've used something in the past, if it hasn't worked, that they won't use it again. But once you break that communication up and that model of care, then you lose that sort of safety check, I think, for patients. And coming back to the toxicity reporting, which I think you asked me, Chair, initially, a lot of that data is now not reported because practitioners are so comfortable. When they see a patient with psychosis that's been on THC, it's not something that we would necessarily report to the TGA. I mean, I would, but not everybody would, because they're aware that these are common, and everybody knows it's an adverse event with these therapies. And that's common to all other drugs too. When they're first out, everybody reports everything because they don't know. Now it's just known that these drugs have these side effects, and so it's not like very interesting or novel news anymore. It's just a known thing. Yep.
Yeah. So there's evidence before us already in the inquiry that millions of people are accessing cannabis through the illicit market. And there's evidence before us that there's very greatly varying strengths of cannabis in the illicit market. So should we be concerned about the fact that presumably those millions of people are not getting medical advice about interactions because they're accessing the drug through the illicit market?
Correct. And experience suggests that those people are actually also taking lots of other medications because they have things like chronic pain or other mental health disorders or issues, for example, and they're seeking help for that. So you're right, this is the reason why if this medication needs to be much better looked after, I think, and if we put the patient first, then at the centre of where the information is, then I think that's much better for people's care.
Yeah.
Another concerning thing that we see sometimes in presentations is people getting medicinal cannabis and they're also taking another product that they've received, sometimes actually at a market or a public place, so they're taking the two therapies together.
Yep.
And they're quite happy to tell you this. They might say, well, I took the medical product or even the ARTG product twice a day as prescribed, but they weren't getting enough relief.
Yep.
So then they started taking other illicit cannabis as well, and now they've got these side effects, and that becomes quite a complicated problem to sort of manage. Yeah.
And this issue of side effects, I mean, it's not just an issue for people taking cannabis as a medication, is it? It can be equally an issue for people that are using it recreationally who might be on other medication.
Correct, and coming back to the numbers, you know, we've seen people coming into hospital from recreational use in the past. It just appears that we're seeing so many more people coming in now with cannabis toxicity and often taking the prescribed product. And I'm not aware of whether all of those people are also taking illicit product, but certainly I've been looking after people that have taken both, and they're quite happy to tell you what they're taking and why they're taking it. But it just feels that there's a lack of overall management of that patient's health. Yeah.
And what do you think is the best regulatory model to make sure that everyone consuming cannabis has access to advice? Whether they obviously choose to follow it's a different thing, but the best model for ensuring that everyone that is accessing cannabis has access to advice about the interactions with other medication?
Well, there should be one person managing their care, and in some jurisdictions it's a community health worker, particularly in regional parts of Australia. It may not actually be a general practitioner, but somebody that manages all of the health information for that particular patient and is their go-to person. In metro centres, obviously it's a general practitioner, but it should be that person who is their family doctor who manages that, because the hospital physicians and other physicians and psychiatrists have a good relationship with those general practitioners. These are models of care that have been built up over many years, and we have good communication. So I think if we are looking at models of care, that historical way of managing and communicating does need to be looked at as well. But certainly I would be pushing for a model where you can simplify communications and the patient, if possible, has actually control of their own data and knows actually which doctor and who's doing what. Yeah.
It's a relatively serious criminal offence in New South Wales to possess or even use cannabis. Do you think that's an obstacle to people generally, maybe young people, or there's obviously all sorts of different people out there? Do you think that's an obstacle to people, for example, being frank with their doctor about their cannabis use, being frank with a pharmacist about it, those being the people that they might sort of often be able to get advice from about these things?
I haven't seen that. People have always been very open in the hospital, and I guess it's a trusting relationship with a health practitioner. But I have, as I mentioned earlier, sometimes if a family has accessed product for a family member and that family member has got sick, and we've been asking whether or not the other doctors in the team are aware of this, there's certainly been a concern around not giving that information back. And it's hard to know whether that's a concern because it's illicit or whether it's a concern because the person has done something outside what their family doctor has been trying to help them with for a number of years.
Yeah. I mean, you can well imagine, though, for example, young people not wanting to tell their family doctor that they're smoking cannabis. I mean, you might have young people seeing doctors with their parents, for example. I mean, I'm just interested, do you think that the existence of a criminal offence of this nature actually obstructs people getting access to advice?
Yeah, not in my experience, but I don't look after people that are young enough to go to the doctor with their parents, but certainly I've always found that patients are quite happy to tell medical practitioners a lot of information. In fact, often tell us more than we were looking for. And there's a whole duty of care and responsibility around what we do with that information. But certainly I think that people understand the confidentiality and the fact that that information is used to actually treat that patient in the best way possible.
Yeah. So you don't think that there's an issue about people getting access to prescription medication in circumstances where they haven't told their doctor that they're using cannabis, but in fact they are?
I think that's a different issue than the illicit police kind of concern.
Oh, okay.
I think certainly some people, particularly if they really have a long relationship with their GP and the GP is unwilling to prescribe it because they don't think it will help them or might cause them harm. We certainly have had patients that have told us they haven't told their GP for that reason.
Yeah. Okay.
Yeah.
Interesting. So when I was a young person, I became aware of this phrase, beer, then grass, you're on your arse. Grass, then beer, you're in the clear, which was a kind of rule of thumb understanding that young people had about how to manage the interaction between alcohol and cannabis. And I was wondering if you could just speak to that.
Well, co-consumption of any medication such as alcohol or cannabis is not helpful for health. And you don't know whether you're going to be the small percentage that will respond in a bad way. And if you're talking about young people, everyone knows young people in their cohort that did very badly with a lot of alcohol or got very sick after smoking a joint.
Yeah.
So I think it's always that concern of not knowing where a person might be on that spectrum. So there may be something in that, but there are always people that get very sick from that combination, and from a health perspective, that shouldn't be encouraged.
Oh,
yeah,
for sure. I mean, it's obviously a very serious issue in respect of motor vehicle accidents, and this interaction between alcohol and THC seems to come up a lot. I'm interested in, again, I mean, to what extent does the criminalisation of cannabis interfere with public health messaging, with messaging in schools and different places? Are we actually not educating our young people enough about these matters because it remains a crime?
Yeah, I can't answer that one, but I can certainly take that on notice. I'm not sure if anyone else on the panel can speak to that. I mean, certainly from a health model, we don't talk about the police aspect of it. We just talk about keeping healthy.
Sure.
And understanding medications and making sure you're getting proper help for an addiction issue, particularly for young people if that addiction issue, whether it's cannabis or alcohol or many others, is affecting their mental health or their ability to hold down a job.
Yep.
And we do know that cannabis does have that effect on the brain. It does reduce your motivation. It also makes it difficult if you're in a job where you have to drive or operate machinery. So these things do have an effect on young people, and we really encourage people to get that help. But you've touched on another area which I also can't really comment on, which is access for young people to get help from an addiction expert or from a mental health facility. Yeah.
So the Royal College of Psychiatrists came along in one of our earlier hearings and gave evidence very strongly in support of decriminalisation of cannabis. Is that an issue that any of you would express a view upon?
I can express a view on the health aspects. I mean, that's certainly a more a political point, I guess, from a health perspective. Things that help people get the treatment that they need, I think would be very well supported.
Yeah.
And if there's a link between those two, the health aspects would be incredibly supported.
Yeah.
But again, if it's not a criminal offence, you still have to be able to provide the health care and the education and the support for those people, whether it's criminal or not. So I'd really encourage a focus on the health aspect, yeah.
Any comment from you two gentlemen on that?
Not from myself.
No, feel free to stay out of it. In terms of these very high THC content medications, is there any evidence that they're being used for non-medical purposes? So they're somehow increasing the access of the general community to these very high THC products? You've talked about people reported to hospital sick. I mean, are they people that have been using it as prescribed to them, or are they people that are somehow getting access to it through that legal system?
The first part is that sometimes, because these don't come from a normal standard pharmacy with all the pharmacy supports on it, they come from a distributor that comes through Australia Post and dropped at their house with some instructions on them about how to use the drug. The people do get a bit confused about how to actually take it. So it might have some labelling on about how much is in there, and people may feel that, well, if they're not getting a response from that amount, they might just double it or triple it. So that's certainly been a concern, that we don't have the usual pharmacy support that as doctors we would like to have when someone gets a drug prescribed for them. So I can comment on that. I couldn't comment on the other aspects, but can any of the team talk to that? No?
Just one thing, I don't know how relevant it is, but the TGA has allowed currently 754 medicinal cannabis products to be accessed in Australia. They have them in 5 different categories. So category 1 is CBD 98%, and that's the Schedule 4 product. Category 2 is CBD dominant. Category 3 is a balanced CBD THC product. Category 4 is a THC dominant product, which when they say THC dominant, they mean between 60% and 98% THC. And category 5 is THC equal or greater than 98%. Now, what's interesting is, of those 754 products, 513 of them are for the category 5 THC equal or greater than 98%. So it seems that the market is definitely for where the highest possible THC is. Now, I don't know, I can't link that to illicit use, but it indicates where the demand is. Yeah.
And the thing, those products would be like oils or sort of distillates. They wouldn't be flowers, would they?
Yes, they are.
They are flowers.
The category 5, 98%. The growth in dried plant material is increasing, and TGA actually mentioned that back in February 2024. And I suspect that since then, because we're seeing at our end very commonly that those sort of products being...
Is that 98% like the ratio between THC to CBD, or 98% of the product is THC?
It's 98% THC.
But there's no product there's no flower on the market that is 98% THC.
I'm just telling you what the TGA has, what they've allowed with their product. Yeah.
I think the highest level of THC you can get in the market is about 30%.
I don't know which market.
I mean, because if it was 98 THC, it would just be a resin.
Well, the reality is there's dried plant material, which is in category 5, 98% THC.
All right, well, we'll take that as given. Appreciate the time for questions has passed. We very much appreciate the work you do. We appreciate you coming along and giving your evidence today. It will greatly help the inquiry. There were some very important questions taken on notice. The Secretariat will be in contact with you in due course for answers in that regard. Thank you very much. You can go. Thank you very much. Colleagues, we will reconvene at 10:30. Sorry. Yeah. And Miss Vandine online. Excellent. Well, good morning to our witnesses, Professor Langham and Ms. Vandine. Thank you for your attendance and participating in this hearing into the regulatory framework for cannabis. Thank you very much for making the time to give evidence. Could I just start with each witness, and we'll start with you, Professor. Could you please state your name, position, title, and swear either the oath or affirmation, which you should have. And you're on mute. Oh, there you are. Now you're not.
I was just going to say, perhaps we start with Edwina while I quickly find the oath or the affirmation for you. My apologies.
That's okay. I will start with Edwina then.
Good morning. Edwina Vandine, Assistant Secretary of the Office of Drug Control. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Professor. And you're on mute.
Yeah, still trying to find the affirmation, but I will give it a go. I solemnly swear that, Edwina, help me out here. Sorry, my name's Professor Robyn Langham. I'm the Chief Medical Advisor of the TGA. I solemnly swear that the evidence I'm about to give is the truth, the whole truth, and nothing but the truth. How's that, Edwina? Thank you.
Is that fine? Yeah, that's fine. That works.
Thank you. My apologies.
Okay. Do you have an opening statement to make?
I do. I'd like to first start by thanking the TGA, the Therapeutic Goods Administration, thanking the committee for the opportunity to appear before the inquiry into the impact of the regulatory framework for cannabis in New South Wales, and also thank you for the opportunity to provide a brief opening statement. I wish to acknowledge that I'm on the lands of the Wurundjeri people and pay my respects to their elders past, present and emerging, and also extend that acknowledgement to any other members of First Nations community with us today. I will note that the federal government is now operating in accordance with the guidance on caretaker conventions pending the outcome of the 2025 federal election. My opening statement is quite straightforward. It's really just to note that the role of the Therapeutic Goods Administration within the Department of Health and Aged Care relating to medicinal cannabis is limited to three things. One is to enable the access to unapproved medicinal cannabis products under the Special Access Scheme and the Authorised Prescriber Scheme. The other is to oversee quality requirements for medicinal cannabis products imported or supplied in Australia through the Therapeutic Goods Order 93. And the last is actions to address unlawful advertising of medicinal cannabis products. I thank you for your time and I welcome any questions the committee may have. Edwina?
Thank you.
Yes, Ms. Vandine.
I just have a very brief opening statement, just to allow the committee sufficient time for questions. The Office of Drug Control, ODC, thanks the committee for the opportunity to appear before the inquiry into the impact of regulatory framework for cannabis in New South Wales to provide an opening statement. I first wish to acknowledge the Ngunnawal people as the traditional custodians on the land from which I'm joining you from today, and recognise any other people or families with connections to the land of the ACT and the region. I wish to acknowledge and respect their continuing culture. The ODC, within the Department of Health and Aged Care's Health Products Regulation Group, regulates and provides advice on the import, export and manufacture of controlled substances, as well as the cultivation, production and manufacture of cannabis for medicinal or scientific purposes to support Australia's obligations under international conventions. As Robyn said, I note that the government is now operating in accordance with the guidance on caretaker conventions pending the outcome of the 2025 federal election. I thank you for your time and welcome any questions from the committee.
Thank you. We'll start with questions from the opposition. Mrs. Carter.
Thank you, Chair. Thank you both for being here and making your time available. Perhaps Ms. Vandine, if I could start with you. Just trying to work out the environment, state regulation, Commonwealth regulation and how they sit together. What impact could cannabis legalisation in New South Wales have on any international drug control treaties to which Australia may be a signatory?
Yep. So Australia is a signatory to the Single Convention on the Narcotic Drugs, 1961. So the United Nations Commission on Narcotic Drugs is the principal policy maker principal making body of the United Nations on drug-related matters, and they have the oversight of not only that convention, but there's a few other conventions, such as for psychotropic substances as well. So we are, the Office of Drug Control is the national competent authority in line with the convention. And under the convention, so all countries, sorry, let me just, so these conventions aim to ensure the availability of controlled narcotic drugs and psychotropic substances for medical and scientific purposes. So they understand that there is a need for these drugs for alleviating chronic conditions and pain in society as well. But their intention is also to prevent the diversion of controlled substances into the illicit channels. Under the Single Convention, cannabis is listed as a Schedule 1 substance, and that is substances that are considered to have a serious risk for abuse. So as the national competent authority under that convention, we are the federal authority that's responsible for regulating the import, export and manufacture of controlled drugs to ensure access to the essential medications. And as I stated before, we're also responsible for regulating the medicinal cannabis cultivation and production, so the domestic side of it as well. So principally, we are to prevent the diversion of narcotic drugs, and we also have reporting obligations as well to the International Narcotic Control Board. Sorry,
yeah,
I'll just stop there.
Yeah, no, that explains the framework, but if New South Wales legalised cannabis, what impact does that have on Australia's federal obligations, Australia's international obligations? What role would the Commonwealth have, for example? You've just described a role in preventing diversion of cannabis, regulated cannabis, medicinal cannabis, into recreational purposes. What role would you therefore need to play? How do the two systems talk to each other?
So the federal government, our responsibility is to ensure that cannabis is only allowed for medicinal or scientific purposes. As a signatory to the convention, it doesn't support the legalisation of recreational cannabis.
Right, thank you. And as Australia as a signatory to a convention, arguably this then becomes a matter of Commonwealth legal competence rather than state legal competence.
Correct.
Thank you. Are you aware of any unintended negative consequences in jurisdictions that have legalised cannabis, especially with regard to spreading of illicit drug markets? The INCB, the International Control Board, is aware and does have concerns for certain jurisdictions where particularly the commercialisation or the cultivation of cannabis for non-medicinal purposes, they do hold concerns that is not aligned with the convention. Okay, thank you. Professor Langham, we have medicinal use of cannabis in New South Wales, and that's been legalised on an evidence base. If we move to legalise recreational use of cannabis, is it the same evidence base? Are there different issues in understanding the evidence base of medicinal cannabis and recreational cannabis, and therefore understanding the risk profiles of each?
Thank you for your question. I guess perhaps in clarifying the first statement, medicinal cannabis is made available. It's not then of the many hundreds of products, only 2 of them are registered on the ARTG. So only 2 of them have gone through that process of evidence base, as you were saying. That's 2 products. One's called Epidiolex and the other's called Sativex, which is they're absolutely just indicated for either a rare form of pediatric epilepsy or for spasms in multiple sclerosis. So apart from those 2 products, the rest have not undergone a process of approval by an evidence base. And so they are considered what we would call in Australia unregistered or unapproved products. So the TGA's role here is really to provide the access scheme and not to have any role in determining whether these products are safe or efficacious, with the exception of our role in the TGO 93, the order looking at quality. So the decision to make that access available was a decision of government.
Okay. And
I guess that's just clarifying the first part of your question. You have to repeat the second question for me so that I can...
Oh, well, I suppose you've answered it in a sense, because we understand that there are risks associated with anything that we take or use. There are studied risks in relation to TGA-approved products, but there would be other forms of cannabis that would be used recreationally. Just trying to get an understanding of where the evidence base is for the risk profile associated with those recreational products that are not TGA approved.
So as I mentioned, the vast majority of medicinal cannabis that's available and accessed in Australia is not evidenced, as it has not gone through an evidence process. Right. When you're talking about legalisation broadly of all cannabis products, I guess the best evidence we have is the experience of international jurisdictions who've gone through that process. One of the best available experiences is that of Canada, who have noticed since legalisation that cannabis use is higher, with I think their quoted figures are something around 22 to 25% of Canadians over the age of 15 using cannabis on a sort of a point study basis. And they've also noticed that though their cannabis-related drug offences dropped, and that more Canadians were obtaining their cannabis legally, there were also some effects in terms of safety and hospitalisation data. I don't have that data with me. I can certainly take that on notice and provide that to you later in terms of the after effects, if you like, in jurisdictions that have moved to a broad decriminalisation.
If you could do that, I'd be very grateful. Thank you.
Happy to.
Yeah. And perhaps the last question from me, Professor, is if cannabis were to be legalised in New South Wales, are there mechanisms, is the TGA involved to stop the diversion of medicinal cannabis for recreational purposes?
So the role of prescribing medicinal cannabis, the decisions around who does prescribe, rests with the practitioner here. The TGA does not make any decisions, as I've said, bar these 2 minor products, not minor products, but 2 products that are used in the minority of cases. The TGA only oversees the access program. All decisions about prescribing, about suitability, about potential side effects, about understanding the current evidence for their use, all of that rests with the prescribing clinician. And in some states, that is largely, by and large, registered medical practitioners, but in some states that also extends to nurse practitioners. In terms of our legal basis for being able to affect diversion, again, that would probably be a question for the legal team of the TGA, and I would have to take that one on notice for you.
If you could, I'd be grateful. Thank you very much.
Thank you. Some questions from me. There's been 2 products approved by the TGA that you referred to, Sativex and the other one, I can't remember the name.
Yeah.
Are there any others that are in the process of being approved?
So thanks for the question. The process of approval requires a sponsor to submit a dossier to the TGA that demonstrate safety, efficacy and quality. Those 2 products have been presented to the TGA by those specific relevant sponsors. There have been none others that have presented, and none that I'm aware of that are currently in the process of doing so. So we have close to 1,000 products that are being prescribed in Australia that have not been presented to the TGA for registration.
Why is that? Why is it that? Because my understanding is that those first 2 products were approved relatively early on. Why are there no other products going through that process?
I guess that's really a question for the sponsors, for the developers of these medicines. For the 2 products that would, so the TGA does not have a proactive role in trying to find products that may or may not be suitable for registration. Our legislated role is to be the regulator and to have products sent to us by process of application.
Is it a lengthy process? Is it an expensive process?
We are a cost-recovered organisation. Yes, sponsors do need to pay a fee for application for registration, and we have legislated timeframes by which we need to be able to turn around an application. And we do have other pathways which are available for priority or provisional approval as well, if there's a shorter time, if the particular condition that's being treated is of such an urgency that those timeframes can be shortened.
Thanks, Professor. We've heard evidence that there's many hundreds of products that have been approved under the Special Access Scheme, 700 or so. In terms of quality control, how is that done? Is there an initial assessment, or I assume there's an initial assessment of the quality of a product, but is there an ongoing assessment? Are these products audited routinely?
So your initial statement that there are over 700 products currently approved under SAS, we don't approve the products. We approve the practitioners to prescribe the product. So they apply to us for approval to access. The process of ensuring that aspects of the Therapeutic Goods Order 93 in mid 2023, there are a couple of aspects to it. One is that there are requirements for manufacturing known as good medical practice, which is a licensing process. And so all manufacturers, both in Australia and external, attest and must adhere to the requirements of that licensing. And the TGA has certainly assisted many sponsors and manufacturers transitioning to those new requirements and working closely with industry associations and responding. So we perform inspections of the manufacturing sites rather than do an audit, if you like, of the products that come to hand.
But internationally, you're relying on the GMP from like an attestation from those manufacturers that they're according with GMP. But you can't do an audit of their actual...
We do. Apologies. We do international inspections as well of overseas medicinal cannabis manufacturing sites. And in some cases, those overseas manufacturing sites have achieved a license and do have ongoing inspections by the local regulatory jurisdiction, depending on which the country that they're in. So we've performed, I think, 8 inspections of overseas medicinal cannabis manufacturing sites, 3 in Canada, 2 in the US, 2 in Colombia, 1 in Lesotho. And the certificates are issued on the basis of those inspections as evidence of GMP compliance for the purpose of TGO 93.
Thank you. A question for Ms. Vandine in the Office of Drug Control. In terms of the Office of Drug Control, we've heard concerns from domestic manufacturers that imports may be leading to an oversupply in Australia that may disadvantage local producers. Does the ODC monitor the balance of supply and demand when it comes to the domestic consumption and supply of medicinal cannabis?
So at the moment, we don't have any data to suggest that there is an oversupply of medicinal cannabis in Australia. What we're seeing is that the demand is been increasing. We have approved, so we have a permit process for our applicants, for our domestic cultivators, producers, manufacturers, and we have approved what could be a sufficient amount for those permit holders to be able to produce to meet the demand. But what we have been seeing historically is that what's been approved, what they've actually done doesn't actually come to almost 50% of what's been approved. So at this point in time, the data doesn't suggest that there is enough in Australia that's been cultivated to meet the demand. So we also have, as you've talked about, we also import medicinal cannabis, and the Office of Drug Control is responsible for administering the import-export licences and permits. And if there was a time that if the government decided to prevent the import, well, that could have a significant effect on the supply in Australia as well. There could be a risk if there's an environmental disaster or any other natural disaster as well that could impact the Australian cultivators, producers. That would have a big impact on patient access to it as well. If we were to prevent the imports as well, that could reduce the competitive market, so there could be flow-on effects to the cost as well. And if there is a big impact to the cost, it does mean that the patients may then turn to illicit sources.
What proportion of the market is being supplied by imports, and has it changed over time?
So I have data from 2023. We're still consolidating the 2024 data, but in 2023, 37% was from Australia, and then 51% was from Canada, and from other sources, it's below 3%.
Okay, so overwhelmingly that's interesting, the amount coming in from Canada, and in terms of the various licensing regimes, could you just explain to me the difference between an import license, the regulatory pathway for someone who is looking to obtain an import license compared to someone who is looking to become a domestic manufacturer and supplier?
Yep, so an application can be made to import medicinal cannabis from another country that is a signatory to the convention. For the reasons for why someone might be importing, part of the application they have to indicate, is it for the special access scheme, clinical trials. Then they would also need to, so what we do is we do a quick police check and so forth. They'd also be required to either have a medicinal cannabis license or permit under the Narcotic Drugs Act, or that they hold a state relevant license as well to be able to import. On the domestic side, we administer the licenses and permits for cultivation, production and manufacture, and part of that is they also have to indicate what their supply pathway is after that process. So to get, the first step is that they have to be able to obtain a license, but that doesn't actually authorise them to start cultivating, producing, manufacturing. That's sort of we look at whether they're a fit and proper person to be able to hold a licence, and that sort of then gives them the knowledge that they can, once they've got that licence, they can actually start investing and building their facilities as well. And then when it comes time that they wish to start the actual activity, they apply for a permit. And that permit's then valid for 12 months.
And with an importer, do they have to license a facility as well? Like if they are importing do the distributors of the cannabis, the handlers in the logistics chain, do they all have to be licensed? Does a processing facility in terms of importation have to be licensed?
From where they're exporting from, they have to meet the obligations in that country, and that will be governed by the convention as well. So they have to meet, the country from which it's been exported has to meet the requirements of the convention. So often they'll incur any of the fees at that point. Once it's imported, it's sort of, once it's cleared the border, it then moves into the state territory regulations.
And so the ODC has no role in regulating or licensing facilities or the logistics or across the country.
No, but I'll correct if saying no is incorrect.
Okay, thank you. And how many cultivators and producers have been licensed and are operational in New South Wales? In Australia and potentially New South Wales at the moment.
Yep. So we have 82 license holders. That was at 28th of February 2025. However, not all of them will hold a permit. So we actually have 29 entities hold a cultivation and production permit, and 10 hold a manufacture permit as well.
And you could take this on notice. Could you, how many of those are in New South Wales? Could you take that on notice?
We'll take that on notice. Thank you.
Okay, thank you. We've
sorry.
Yes.
Just going to your question on how many are in New South Wales. We currently have at 28th of February. These are permit holders. So there are 4 that hold a cultivation and production permit, and there are 2 that hold a manufacture permit.
Thank you. In terms of how you how do regulators coordinate between the federal and state level? Is there a round table that you go through? Like, what entity, if any, is there that looks at the interaction of state and federal regulation in this area and reforms, etc., or issues as they emerge?
We do meet regularly with the state and territory departments, both law enforcement as well as the health and primary industry departments.
Thanks. What about the TGA?
Sorry, the TGA in the sense of?
Well, how do you coordinate and the regulation, and is there a framework for you to discuss issues that are emerging in this space with relevant state agencies?
Yes, we have regular meetings with stakeholders. This is a very complex area, I'm sure you can understand, of the regulation of this system, given that we're responsible for regulating the product. APRA is responsible for regulating the clinicians, and the states and jurisdictions have their own roles as well. And so in the last 12 months, I think we've had 2 meetings, broad stakeholder meetings, to talk about specific issues in this space.
And what are some of the issues that have been coming up? We've heard some issues about prescriber practices. What are some of the issues that have been on the agenda?
From a TGA perspective?
Yes.
I'm not really sure I'm able to comment, given our caretaker convention at the moment.
Oh, okay.
Apologies.
Okay. All right. No, thank you very much. Mr. Lawrence.
Thanks very much, Chair, and thanks, witnesses, for your attendance. Miss Vandine, just a couple of questions for you. Firstly, am I right in thinking that the 1961 convention is the main international instrument that obligates Australia to criminalise cannabis?
So the criminal code in Australia that makes it there's a federal level. There's an offence for the possession. So yeah, and the convention it is also open to other measures as well, not just criminalisation. There is a large focus on education, also measures for decriminalisation and depenalisation for personal use as well as possession, but not for the cultivation of cannabis.
Yeah. So your understanding of the international law position is that there's no prohibition in the instruments that Australia is bound by on decriminalisation broadly?
That they're bound by it?
There's no problem in terms of our international law obligations with decriminalisation of small quantity possession, for example?
So they've made it clear in their report that they are open to measures of decriminalisation, depenalisation.
Yeah, and they're certainly open.
And that's in their 2022 report.
Right, okay, thank you. And they're certainly open to diversion of users from the criminal justice system?
Of personal use?
Yeah. So the ACT has decriminalised, as I understand it, the possession of small quantities of cannabis. Are you on top of how that decriminalisation interacts with the Federal Criminal Code offence of possession?
So the criminal code is still the federal, it covers it federally.
Yeah.
So I guess there is with the ACT, under the federal law, there is still that offence for possession, whereas under the ACT, they have decriminalised possession of small quantities. The concern that is held, though, is that it also decriminalises cultivation.
Yeah. Around the time of the passage of the ACT law, there was some discussion about, I think it might be section 308 of the Commonwealth Criminal Code. Sorry, 313.1 of the Federal Criminal Code, that creates a defence to Commonwealth liability where conduct is justified or excused by or under a law. And there was some political level discussions where the ACT Attorney General, then Attorney General, said that they believed that would create a defence to any federal prosecution. And the then Commonwealth Attorney General, Christian Porter, had a different view, and he said that he would expect the AFP to continue enforcing federal law in the ACT. Has that discussion, to your knowledge, gone anywhere in terms of whether 313.1 of the Federal Criminal Code is considered to provide a defence to a possession because of the ACT law?
This might be more of a question for the Attorney Generals.
Yeah. So to your knowledge, since the ACT decriminalised, has the AFP, acting under the federal law, sought to commence criminal proceedings against anyone for small quantity possession?
Sorry, I won't be able to answer that question. Sorry.
Yeah. Okay. In terms of some evidence you gave earlier to Miss Carter, she asked you about legislative competence of state and federal parliaments, and I think you agreed to the suggestion that because of the international legal obligations, that decriminalisation or legalisation would be a matter within the competence of the federal parliament rather than a state or territory parliament. I think I've fairly summarised that. So I just wanted to ask you a couple of questions arising from that. So in giving that answer, you weren't suggesting that as a matter of Australian domestic law, it wouldn't be open to a state or territory parliament to decriminalise or legalise, were you?
So at the federal level, if the federal government was to legalise or decriminalise, that would be a matter for the federal government.
Yeah. Sure, but you weren't suggesting, for example, that what the ACT did is somehow not within the competence of the Territory Parliament.
Yeah. So that'd be another legal matter for the Attorney Generals.
Okay, yeah. And you weren't suggesting that it's somehow outside of the power of either a state, territory or federal parliament to legislate inconsistently with international law, were you?
So the issue with if a state or territory were to legalise cannabis for recreational purposes, a breach of the convention, it does have an impact as well. We could be prevented from importing, which would impact access for patients as well.
Okay, yeah. So how does that sit with, like, let's say there was decriminalisation of small quantity possession, which you've said isn't inconsistent with the relevant conventions. How would that sit with any risk to importation?
It may be okay, and we'd have ongoing conversations as well with the International Narcotic Control Board as well.
Yeah, so it wouldn't necessarily lead to revocation of those liberties under the convention?
There would be conversations, but yeah, there's no definitive answer until we would have those conversations. We'd have to see what the proposals are as well, to be able to make a definitive answer.
Yeah. So to your knowledge, has the federal government sought to use their power under the Self-Government Act to disallow the ACT decriminalisation laws?
Sorry, it's another question for the Attorney Generals.
Yeah, okay. And what's the mechanism, to your knowledge, under these narcotics conventions and the like, to vary the conventions? So to change, for example, the prohibition on cultivation for recreational purposes and things like that?
So it would need to be taken to the convention.
Okay. Thanks, Chair.
And then, yeah, agreed by all.
I've just got some questions.
Okay,
Just,
thank you for that, Ms. Vandine.
how much longer have we got? 8 minutes. Yep. How many approvals has the TGA made for access to medicines? Do you track that? How many individuals have been, or doctors, and their patients have been approved for access to medicinal cannabis?
We don't. Thank you for the question. We don't. We can't really provide accurate numbers of the number of patients because one patient could be associated with multiple authorised prescriber approvals from the same prescriber, or multiple single approvals for different products. So from the majority of our approvals indicate that. When we combine chronic pain and anxiety, we have around 600,000 approvals, but then that may not necessarily reflect the number of patients. Our authorised prescriber process gives us 6 monthly details and doesn't contain any patient details, so we can't understand whether those are duplications. So and equally, we don't hold any prescription data.
Thank you. Just a question to the Office of Drug Control. What's the quantum of cannabis being approved and used in medicinal cannabis in Australia, and like in terms of in total, and also how many tonnes are we importing? How many tonnes are we producing in Australia?
Yep, sorry, just give me one moment. Yep, so the amount that was are you okay with 2023, just 2023?
Yeah, that's fine, yes.
21, 22 and 23. So in 2023, there were 42 tonnes that was imported. We also exported just over 2 tonnes. And the amount that was produced in Australia was just over 26 tonnes.
Thank you.
And that's of dried flower, sorry.
Of dried flower, okay.
I've just got a quick question.
Yeah, sure. Ms.
I
Fairman.
think this is thank you to the TGA. Whose responsibility is it to develop clinical guidelines for medicinal cannabis, so guidelines for clinicians? Is that the TGA's responsibility, or does it sit with another group?
So the TGA, thank you for the question. The TGA has no legislative capacity to give clinical guidance or clinical advice, as we are the regulators of products only. When the federal government made a decision to establish or to make available medicinal cannabis under the Special Access Scheme and Authorised Prescriber pathway, there was some work done back in 2017 on an evidence base surrounding a certain number of conditions, and I think it's fair to say that was 2017, and now it's 2025, and there has been some changes made to those guidelines to make them contemporaneous, certainly for the patient facing process, but they're really the clinicians who are prescribing them would look not only to the existing TGA documents that are there, but also externally. College of GPs, the Royal Australasian College of General Practitioners have a document on their website, and there are also some other international documents that are available. But the responsibility for clinical guidance does not sit with the TGA.
Okay, so for example, if there's a specific opioid that's marketed by a global pharmaceutical company, for example, that the TGA has, what's the word for it?
Registered,
Thank you.
approved.
Thank you, approved. That pharmaceutical company would provide, I assume, a very comprehensive guidelines themselves for clinicians. We have, hundreds, again, in terms of the prescribers that apply for the Special Access Scheme, and hundreds of products, but they don't necessarily have that level of clinical guidelines that are provided with them. There does seem to be a gap there where the global pharmaceutical companies have the resources and the incentive, if you like, to provide that. The RAC GP, is it not necessarily their role to do that for everything? Is it? Is there a gap there that you can see?
I think, according to our legislation, it is the responsibility of the clinician to be able to be across the research, the evidence, and the suitability of that drug for the patient. Without a drug being presented for registration, without all of that relevant data demonstrating safety and efficacy and quality, the TGA is not able to do that.
Okay, thank you.
It absolutely, under our legislation, it's the responsibility of the clinician.
Thank you.
Thank you, Ms. Fairman. Any other questions, colleagues?
No, thanks, Chair.
That's it. All right, thank you very much. We very much appreciate your attendance and the evidence you've given today. It will greatly inform the inquiry, and I'm not sure, I think there might have been one or two questions taken on notice. If there were, the Secretariat will be in contact with you in due course. But thank you very much for the work you do and your attendance today.
Thank you very much.
Thank you.
Thank you. Morning, Dr. Nicoletti. Before we commence, could I just get you to state your name, your position title, and swear either the oath or affirmation?
Thank you. My name is Dr. Teresa Nicoletti. I am currently the chair of the Australian Medicinal Cannabis Association and also a partner of Mills Oakley Lawyers.
Fantastic. Thank you very much. Could I get you to swear either the oath or affirmation, please?
Yes, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Would you like to make an opening statement, Doctor?
Yes, I would. I'd first like to just give you a brief summary about AMCA, the Australian Medicinal Cannabis Association, and then a brief snapshot of AMCA's position in relation to this inquiry, which I'm sure will prompt many questions from you. So firstly, I co-founded AMCA in 2020 with Lucy Haslam, whom I'm sure you know is probably the most highly regarded advocate in the medicinal cannabis sector for her pioneering work, which I think actually led to the legalisation of medicinal cannabis. We saw a need for an association that considered the interests of all stakeholders. We also have another association, a Medicinal Cannabis Industry Association, which is more focused on industry, but we felt that the stakeholder interests needed to include clinicians, other healthcare practitioners like pharmacists, and also, of course, patients. So AMCA is not-for-profit. It's registered with ASIC and with ACNC, and it also has DGR status. We exist for and only through the generous support of our membership, and so we have a range of fees to enable individuals at all levels to become members, and we just have enough funding to survive so that we can do the work that we need to do to facilitate the industry. We have a board of directors, and our focuses include supporting veterans, changing the drug driving laws, making medicinal cannabis more affordable to patients, and creating a more even playing field within the industry for domestic and imported products. We have more than 500 members, so we're by far the biggest association. So if I can turn to a brief position statement. As the largest membership association in the medicinal cannabis industry, we recognise that the landscape for cannabis use in Australia is evolving. And in addition to the legalisation of cannabis for medicinal purposes in 2016, cannabis use in more recent years, particularly with the ACT legislation, has been shaped by the legalisation of cannabis for personal adult use. And this perhaps represented the first shift in Australia's change in cannabis policy. And now there are further proposals in Victoria and New South Wales to follow similar pathways to legalisation for personal use in those states. From the perspective of AMCA and the medicinal cannabis industry more broadly, what we would like the committee to appreciate is that the legalisation for personal use needs to be distinguished from the use of cannabis for medicinal purposes. And AMCA's primary concern is to ensure that any steps that are taken towards broader legalisation of cannabis for recreational purposes ensure the viability of the medicinal cannabis industry, which many Australian stakeholders have invested very heavily in. One thing we do acknowledge, however, is that the legalisation of cannabis for adult personal use in the ACT appears to have ironically played a role in reducing stigma towards cannabis generally and increasing public awareness about cannabis as a substance. And it has perhaps led to broader acceptance of cannabis's potential benefits. And ironically, this shift in perception may have actually assisted the medicinal cannabis industry as more members of the public and healthcare professionals become more comfortable with its use. However, I have to add that the limited proposed use of cannabis for adult personal use is very different from some of the models in other jurisdictions, which include much broader recreational use for retail sale and setting up different markets for cannabis use. And I think the medicinal cannabis industry would have a lot more to say if a proposal was put forward to legalise cannabis more broadly than what is proposed by the New South Wales bill. So the legalisation of cannabis for personal use does present some challenges. First and foremost, legalising adult personal use on the one hand while maintaining road traffic laws that prescribe strict liability offences for the mere detection of THC in body fluids while driving is not good overall policy. It is decriminalisation on the one hand, but criminalisation on the other hand by allowing that criminal offence to be maintained. And so the issue of impairment is still very poorly understood and it still has not been addressed. But while those laws remain, the legalisation of personal adult use may inadvertently lead to a rise in drug-related offences for THC in body fluids. Secondly, the legalisation of adult personal use can lead to confusion between medicinal and recreational use. Our concern is that it can lead to self-medication based on a misconception that cannabis is cannabis, when there are hundreds and hundreds of different strains of cannabis that have different effects and different potential benefits and risks. And self-medication may lead to poor health outcomes. This is where we think that education of both the public and healthcare providers on the distinct and regulated nature of medicinal cannabis is very important. And the public's understanding of the need for safe, tailored treatment plans using high-quality products of known composition overseen by medical professionals remains central to the ongoing success of the medicinal cannabis industry in Australia. AMCA does acknowledge that there is an increasing momentum towards legalisation for recreational purposes, and it is not opposed to the passing of the New South Wales bill. However, we emphasise that proper education and public health messaging needs to distinguish recreational use of cannabis from medicinal cannabis so that the two frameworks can operate harmoniously and the benefits of the controlled, more evidence-based approach to medicinal cannabis treatment and the current mechanisms that ensure that patients are receiving high-quality products through a regulated framework are not undermined by recreational use. Thank you.
Thank you, Dr. Nicoletti. Some questions from the opposition. Mrs. Carter.
Thank you, Chair, and thank you, Dr. Nicoletti, for being here. It was very interesting, I thought, your analysis of the framework of the importance of not conflating, should legalisation or decriminalisation occur, not conflating medicinal use with recreational use. And I think you pointed to education, public health messaging. Are you aware of any jurisdictions anywhere where that public health messaging has successfully been able to differentiate between medicinal cannabis and recreational cannabis?
I am not aware. The frameworks internationally have either been based on retail models that treat recreational cannabis like a consumer product. And my view is that the Australian regulatory framework is probably the most focused on treating medicinal cannabis as a pharmaceutical rather than a more broad perception in other markets that it has health benefits.
And you raised quite rightly the issue of impairment, especially with respect to driving. We had evidence this morning that we don't really have the sort of alcohol comparator of 0.5 or whatever. Are you aware of any framework or any research or any testing that's available so that we can test for cannabis impairment in driving the same way we test for alcohol impairment?
The issue with cannabis, as I understand it, is that each person responds differently to cannabis. And one person may be impaired, whereas another person taking the same quantity of cannabis containing THC may not be impaired. The other issue is around tolerance, and as a person becomes more accustomed to using medicinal cannabis, they become more tolerant of it and less impaired. And so whilst there has been research, the research has demonstrated that the issue of impairment is not of such concern as legislators have made it out to be, in the same way as alcohol is impairing. And so I don't have the answer for you, but one thing I do recognise most importantly is we cannot continue with a situation where we have legalised medicinal cannabis for medicinal use and are sanctioning individuals who are legally taking it for that purpose simply because they need to drive for whatever purpose, particularly for work.
But aren't there other drugs that are prescribed medicinally that preclude driving because of the side effects of those drugs?
Well, there are many drugs that could be potentially impairing, but in relation to those drugs, other than morphine under our state legislation, for which there is an excuse if someone has a medical prescription, there are many other drugs, not just morphine, other opioids, benzodiazepines, some of the antipsychotics, which are quite impairing. And those drugs contain information in their product information or consumer medicines information that states that a patient should not be driving or should take caution when driving or operating machinery. But there are no prohibitions as such. And I can't see why the same cannot be held for medicinal cannabis.
So are you arguing that even though persons could be impaired while driving, it should be a matter for them to decide whether they drive and what risk they might pose to other road users?
Well, yes, in the same way as is the case for many other medicines that are impairing or potentially impairing.
But doesn't the logical extension of that argument mean that we would lift restrictions on alcohol and say to people, you choose whether you will impair or endanger other users of the road?
Well, yes, you could run that argument, but the evidence of alcohol is that levels above 0.05 have consistently shown impairment, and that is a reasonable benchmark. The same cannot be said for medicinal cannabis.
But is the absence of a as yet to be ascertained reasonable benchmark, is that evidence that people driving under the influence of cannabis do not have impaired reaction times or other impairments which make them potentially dangerous to other users of the road?
So the evidence has consistently come back that the level of impairment in many cases is not similar to alcohol. I don't have an answer for you.
Are you able to provide on notice any evidence you have about the relationship between cannabis and impaired driving?
Yes, I can do that, yes.
Thank you. From a medical perspective, what are the risks of conflating medicinal cannabis use with recreational use?
Well, as I said before, the problem of muddying the waters with the two and individuals adopting a perception that if they can grow up to 6 plants of cannabis in their homes, they can treat their medical conditions. The issue with medicinal cannabis is there are so many chemovars that have different composition, and there are hundreds and hundreds of different chemovars which have hundreds of different cannabinoids, hundreds of different flavonoids, terpenes, isoflavones, that make them one medicinal cannabis plant compositionally very different from another. And there is a lot of research that shows that certain strains or chemovars of medicinal cannabis may be very beneficial, for example, in the treatment of epilepsy, whereas other strains will have no effect whatsoever in in treating those conditions. And so our concern is that there needs to be sufficient education to understand the difference between recreational use and to understand the need to seek medical advice if a person, a member of the public, does have a medical condition that they feel could be treated with medicinal cannabis. And one thing we don't want to see is patients assuming that cannabis per se will be a panacea for all conditions.
Are you aware of any research that's been done about people using medicinal cannabis and then also using cannabis recreationally, and what the interactions between the two different types of cannabis have been?
I'm not aware of any research.
Great, thank you. Thanks, Chair.
Kate?
Thank you, Chair. I just wanted to pick up on the drug driving questions. So, for example, if someone was taking, as prescribed by their doctor for severe pain, endone or tramal, for example, which are, I think endone's still Schedule 8, maybe, exactly. So if they got behind say they drove, they took a few hours later, they drove, they were a bit drowsy, they got pulled over in terms of drug driving. One of the issues here, and the difference, isn't it, between medicinal cannabis users who are potentially using it for the same pain maybe, is that firstly the police aren't testing for those drugs.
Correct.
Right, so they're not testing for those drugs. So even though those people may be, slightly more impaired, it might not be coming up for the police, but they're a bit wonky. They're still behind the wheel, but that's a legally prescribed drug. That's correct. I'll just get you, for the Hansard's sake, you nodded.
Yes,
yeah,
that is correct.
And for medicinal cannabis users, they're advised really by their clinicians around when to drive and when not to drive. Like, doctors do that for most drugs. Is that correct as well? Is that your understanding?
Correct.
Yeah, and so what you're arguing for medicinal cannabis users is really the same application of the law now that medicinal cannabis is legal, similar to any other drug.
Correct.
And it's different to alcohol because it's a medicine.
Yes. You raise an interesting point as well. There may be patients who are taking drugs like endone and also taking medicinal cannabis, and they may be tested on the roadside and there may be detection of THC. But what's unknown here is what is causing the impairment, if they are impaired, whether it is actually the medicinal cannabis causing impairment or actually the endone causing impairment. And so there's a disparity here that is really unfair in the context of patients who are legitimately being treated for a medical condition with medically prescribed medicinal cannabis. And you're right, medical practitioners will advise patients who are taking morphine, oxycodone, which is endone, tramal, or any other impairing drug, not to drive or to take caution, but ultimately patients may need to do that for their work reasons.
What's your understanding, therefore, of the impact, the difference, for example, in Tasmania and the rest of the country? Tasmania is, obviously one of the only jurisdiction where they don't have, where they have an exemption.
Yes.
Is it your understanding on what you've researched that has had any difference in terms of the drug driving or road statistics?
I don't know the difference it has made, but the point I made earlier was that allowing adult personal use does run the risk of seeing more roadside offences if you suddenly have households feeling comfortable to grow medicinal cannabis and then not be fully aware of the consequences if they then drive.
Yeah, that has to be sorted out.
Well, it does need to be sorted out, but at the very least there needs to be strong public messaging around what recreational use means and the potential consequences.
Yeah, that's all for me for now.
Thank you. Since medicinal cannabis was legalised nationally, has it been popular with patients? And what sort of growth have we seen? And for what particular conditions are we seeing the growth, if there is any?
I wouldn't use the word popular. I think there has been a strong uptake of medicinal cannabis in terms of mainly conditions like chronic pain and anxiety, which have seen increasing numbers of patients taking it. Some of the positive stories around the use of medicinal cannabis have been that patients have been able to reduce their reliance on other medications. And so the increase that we have seen really aligns with practitioners becoming more comfortable with medicinal cannabis, some movement in price so that medicinal cannabis is more affordable as supply and demand forces have led to a decrease in price over the years that we've seen legalisation. But also there have been a lot of medicinal cannabis clinics that have been established in recent years that have really facilitated access to medicinal cannabis. And they were initially set up because there is a large proportion of the GP community who was uncomfortable about prescribing medicinal cannabis themselves. So medicinal cannabis clinics established so that patients were able to go to an alternative medical practitioner to prescribe medicinal cannabis. And I think that's seen the biggest increases in more recent years.
And in terms of medical practitioners who are now prescribing, like, are there more and more GPs or nurse practitioners who are now more comfortable? Is there a growth in the numbers of practitioners, or has that remained relatively stable?
I don't see the general GP community really increasing their prescribing of medicinal cannabis. It's to some extent they haven't had to address whether to prescribe it themselves because these medicinal cannabis clinics have addressed that issue. And in some respects, I would have liked to more see the GP community being comfortable to prescribe because they have the relationship with their patients and they understand the patient's full medical history. And the medicinal cannabis clinics were a separate avenue for patients to obtain access to medicinal cannabis, and there wasn't always that relationship between the medicinal cannabis prescriber and the patient's usual GP. But we are trying to address that, to encourage best practice, which would be that there is a shared relationship between the medical practitioner that prescribes medicinal cannabis and the patient's usual GP.
And what about quality control? There's been we've heard evidence that there's some inconsistency in the supply and some uncertainty about actual, like the potency, or in terms of THC, some issues around whether I've seen reports and I think we've heard evidence that there's some issues around some of the regulation of imported product for quality. Do you have any reflections on those issues?
Yes, so AMCA has received a number of reports or information from either members or other stakeholders within the industry that it has raised concerns about quality, more of incoming product, for imported product, than product derived from domestic cultivators, producers and manufacturers. All suppliers of medicinal cannabis need to comply with Therapeutic Goods Order 93, as Professor Langham stated. Whether that is happening, though, is another question. And in relation to some of the reports that AMCA has received, we're of the view that it isn't happening in all circumstances, i.e. Suppliers aren't ensuring compliance with TGO 93 in all circumstances. The only way to try and address that would be for, and the TGO is not going to like this, my saying this, but I feel that there should be some quality checking of products that are being imported and also of domestic product, because that would then create more of an impetus for companies to ensure that they do comply.
And we've also heard some evidence today and previously that I think it was put to us that there was anecdotally reports of misuse, I would put it like that, of cannabis or adverse outcomes, and an uptick in people presenting with a range of sort of cannabis misuse disorders, like or associated with cannabis use, psychosis or nausea or associated. Is that something that AMCA has heard, or how would you respond to that?
So yes, we have heard it, but one of the things AMCA has asked for is evidence. And so you may be aware that the AMA recently implored the government to consider restrictions on medicinal cannabis use on the basis that patients were presenting to emergency department with a range of concerns such as psychosis. One thing we have asked for repeatedly is evidence that this is happening. So it's all very well to write a letter saying individuals, members of the public are flooding the emergency department, but we would like to see that evidence. And the information that we've obtained is that there doesn't seem to be any evidence of additional cases coming to emergency department that relate to psychosis or other adverse effects of cannabis. But if the things that have not been considered is what is the denominator here? So if you do have 100 cases of psychosis across Australia in emergency department, what is that as a percentage of how many patients are actually taking medicinal cannabis? And so if you have 1 million patients taking medicinal cannabis and there are 100 cases of adverse effects, then that's a very low number based on the number of the number of patients using. Secondly, we don't have any evidence as to whether their psychosis was causally related to medicinal cannabis, i.e., was cannabis the only medication they were taking, which would tend to support a causal relationship, or were they taking multiple other medications such as morphine, oxycodone, benzodiazepines? And we don't have that information either. So AMCA has asked for this information, and AMCA would welcome the opportunity to work with the AMA and any other representative bodies if there is actual evidence that this is occurring. And we would be the first to step in line and say, well, how do we address it?
A lot of jurisdictions have, or an increasing number of jurisdictions, both in Australia, overseas, have begun, have travelled down the pathway of liberalising cannabis laws when it comes to medicinal cannabis, that then has moved into a liberalisation of adult use cannabis laws. So if we look to the States, Canada, Germany, other jurisdictions, what countries are doing it well, in your opinion? What are some of the jurisdictions we can look to that have managed that staged approach to cannabis deregulation, decriminalisation or depenalisation, legalisation, however you want to put it, well, in your opinion?
So I think Canada has a regulated model where there is some control over the quality of medicinal cannabis and accessing it through dispensaries. When you say doing it well, there are various models, but the Canadian model, I think, perhaps aligns reasonably closely with a medicinal cannabis type model because it does have a regulated model which requires supplies of medicinal cannabis to be licensed and for cannabis to be accessed through licensed dispensaries as well. And so if at the moment, what is being proposed in New South Wales is a very, if I can say, low-level legalisation for recreational purposes. The overseas models are not really relevant to what's being proposed here because they're more retail models which have tax revenues, and it's not really the right conversation to be having in terms of what New South Wales is proposing to do. But certainly if there was to be a conversation about broader recreational use in that retail type model, then I think we'd have a lot more to say about it.
Thank you. The government. Mr. Murphy.
Yeah, look, I just wanted to go back to this issue about the roadside drug testing, Dr. Nicoletti. And really, the issue is that the roadside drug tests just detect the presence of THC. Isn't that correct? They don't actually have anything to do with the level that might result in impairment. There's no way for that test to test impairment, is there?
Correct.
So, so really your complaint is that they're being unfairly targeted, cannabis users, in that they're just using their medicine in the way that's been prescribed by a medical professional, yet this test picks up the presence of that THC in their system.
Yeah, it's not really unfairly targeted. It's a hangover of the legislation pre-legalisation, and it hasn't been addressed. And it should have been addressed, in my view, when medicinal cannabis was legalised. But there seems to be the resistance to actually changing the road traffic laws, although Victoria has stepped up and allowed discretion in the context of a person that has a medicinal cannabis prescription, and that should at least be followed in New South Wales.
Because there's still an offence, of course, for driving
It's a
while
strict
impaired.
liability offence, and it's an automatic disqualification of licence. There's no discretion under the legislation.
Yeah.
Even if a
and if
patient
that was
has a
to be
legal
removed,
script.
there's still an offence for driving while impaired that police could rely on
Under
in
the
circumstances where
Well,
somebody's impaired.
So you're correct in stating that it's the mere detection that is a strict liability offence, even if it's in nanomolars in body fluid, and even if the person doesn't have any evidence of impairment. And there's no accepted quantitation of how much THC will actually cause
Because
impairment.
everybody reacts differently, you
That's
can't
right.
have a standard like we do for alcohol, where we do know that the more you consume, the more impaired you become, and we have standards that, previously we had this, you could have 2 beers in the first hour, 1 every hour afterwards, and stay under 0.05. There's no real way to do that with cannabis.
No.
Certainly at the moment.
Correct.
Yeah, thanks.
Thanks, Chair. I've got a few questions. Just on that driving issue, the offence you're talking about of driving with the presence of certain drugs in oral fluid, blood or urine, that's in section 111 of the Road Transport Act. And it applies when a prescribed illicit drug is detected, and the only drugs in the definition in that act of prescribed illicit drug are THC, methamphetamine, ecstasy, and cocaine. Is that right?
Yes.
Yep. So drugs, so prescription drugs like Valium and benzos are not in that definition, correct?
That's correct.
Are you able to give us your thoughts on how much of the cannabis being prescribed through the medicinal cannabis scheme is actually being consumed for recreational purposes?
That's a very good question. It's a very vexed question because one of the concerns of AMCA with the rapid increase in prescribing of medicinal cannabis, whether it has set up a quasi-recreational scheme. I don't have any hard evidence of it. I don't have any numbers to talk to you about, but there is definitely that concern.
And how do you think full decriminalisation and or legalisation of recreational use would impact the medicinal cannabis industry?
In the levels that the proposed New South Wales bill is proposing, which is 6 plants per household, I don't know that it'll have much difference at all on the medicinal cannabis sector. Certainly broader legalisation would.
Yeah, in what way do you think?
Increasing in supply, increasing the ability to access.
So people would be less likely to seek to access cannabis through the medicinal scheme if there was a full legalisation scheme, do you mean?
Possibly. It depends on what sort of regulated supply we have and would ultimately depend on quality as well.
Yeah. Like, let's say we had a scheme where anyone who was an adult was able to go to a pharmacist, for example, and access cannabis without having to provide a prescription or proof of a medical condition. What impact do you think that would have on the medicinal cannabis industry?
Again, it depends on what the supply chain looks like and so who's going to manufacture and supply that medicinal or non-medicinal cannabis. So if the medicinal cannabis industry pivoted and supplied that product, then it may just be a shift and not actually impact the industry. But if there was wider access, then it may actually decimate the medicinal cannabis industry.
Yeah. So does your organisation have a position on full legalisation?
Yes, we're opposed to full legalisation because we think it's a public health concern more than anything.
Right.
And that is because medicinal cannabis is not an easy product to understand because there are hundreds of chemovars. And our view is that the public shouldn't be self-medicating with cannabis because they have no idea of the composition of their product.
So is your organisation a membership organisation?
Yes, it is.
Yep. So your members' industry could be severely adversely affected by legalisation?
Again, it depends on what that legalisation looks like.
Yeah,
and again,
form?
I'm talking about broad legalisation.
Yeah. Okay. So that's part of the context, is it, in which your organisation has reached that position to oppose full legalisation?
Yes, correct.
Can I just ask a clarifying question around what, like
Sure.
in terms of full legalisation compared to like a particular regulated market where some cannabis is available outside the medicinal cannabis scheme. So is there somewhere there that you support? When you say full legalisation, is it everything other than a medicinal cannabis scheme, or is there like a well-regulated market where people can still buy cannabis recreationally without a script, and they kind of know, more in terms of what they're receiving? Is there some middle ground or no?
Well, I don't think that there is, because we have a world-class medicinal cannabis scheme that very carefully categorises products according to their composition has a very strict standard of quality, and knowledge of those products is what is making the medicinal cannabis scheme work here, and is the reason why so many patients are getting benefit from medicinal cannabis. Once you introduce broad legalisation for recreational use, I cannot see in the longer term why the public would even bother going to a prescriber to seek prescribed medicinal cannabis. They might adopt the self-medication pathway instead and decide for themselves that they will opt for a recreational product that might be cheaper.
Sure, there are. What's your view in terms of how many clinicians, for example, are prescribing medical cannabis that are prescribing other things, and patients are going to see their GPs or health professionals with, for example, anxiety or pain. They'll continue to do that because they've got anxiety or pain and they want to speak to a health professional. Isn't there surely still a significant number of people that will continue to see a health professional who will continue to prescribe medicinal cannabis as opposed to everybody going to the recreational? And the other, sorry, just on this, in other countries, jurisdictions, has there been a very demonstrative slip away from people seeing their clinicians, for example, to get prescribed medicinal cannabis?
Well, those models didn't really follow the same structure as Australia. Our framework has now been in place for 9 years and is a well understood framework with very strict regulatory standards. No other market has really followed that. It's followed more of a decriminalisation or recreational pathway. So it's very difficult to align our framework with any other jurisdiction for that reason. And the issues you raise, yes, there will be patients who, notwithstanding legalisation for recreational use broadly, may continue to see their medical practitioner to continue to be prescribed medicinal cannabis. But one of the biggest barriers to access at the moment is cost. And if a patient can access a recreational product for much less cost than a highly regulated product to try and treat their condition, they may do that. And that's one of the main reasons we're not supportive of a broadly recreational program.
One last question, Chair, just about cost. What is, in terms of the association's recommendations as to some of the easiest things that can be done to reduce those costs? Because we hear from many people who simply can't access medicinal cannabis because of the very exorbitant cost of that. So what's the association's recommendations there for us?
It's an invidious position that the industry is in, and one of the things I often say is you can't have your cake and eat it too. The regulatory framework that we have in Australia is unique because we've essentially provided for broad access to what are unapproved therapeutic goods and haven't gone through the normal regulatory framework of being assessed by the TGA for quality, safety and efficacy. And one of the requirements for reimbursement, which would make medicinal cannabis more affordable, is for products to be registered in the ARTG. And so if we want subsidisation, currently, under the current legislation, the only way to do that is to obtain registration in the ARTG, which would then allow an application to be made to the Pharmaceutical Benefits Advisory Committee for reimbursement. In the absence of the ability to do that, because the legislation is fixed, the only other opportunities are normal supply and demand forces as supply increases, and it's regulated with demand. The prices may fall, or otherwise look to potentially private health insurers that may provide some subsidy for medicinal cannabis.
Doctor, why hasn't anyone done that from the medicinal cannabis industry for THC for pain?
Done what, sorry?
Haven't registered under ARTG.
Okay, I can tell you why. The registration process is quite onerous. When Professor Langham referred to a dossier that's required to be submitted, medicinal cannabis is a Schedule 8 medicine in the main. CBD is Schedule 4, but in any event, they're prescription medicines. The dossiers that are required to be submitted need to establish quality, safety and efficacy. And quality can be established, that's manufacturing process, demonstration of quality through a range of production batches. But it's the safety and efficacy that's the problem. And the only way to establish safety and efficacy sufficient to support registration is through clinical trials. Clinical trials are very expensive. We're talking millions of dollars to generate the data required to support registration. And so that is a main barrier to the medicinal cannabis industry investing in generating data to support registration. And if you're a company operating in this sector and the government has created a regulatory framework that allows commercial supply, de facto commercial supply, even though it's special access scheme or authorised prescriber scheme, why would you invest then in generating clinical trials? Because you can effectively continue to supply the product to hundreds and thousands of patients.
Because you might want to establish its efficacy.
The efficacy for chronic pain that you're talking about in particular, that efficacy has been established through real-world data on the number of patients that are deriving benefit for that indication, but that isn't sufficient to support registration approval, because registration approval needs controlled clinical trials that regulates the inclusion and exclusion and doesn't have any confounders. And so the consensus in the industry is probably that there is sufficient anecdotal evidence of what medicinal cannabis is useful for, and clinicians will continue to prescribe on that basis. And the focus of industry, and I don't say this in a negative way, it's the reality. The focus on industry is the commerciality of its products, not whether patients can afford them. And patients are continuing to go to their doctors and have medicinal cannabis prescribed, and that's leading to a viable industry.
Thank you, Dr. Nicoletti. Well, the time for questions has, in this section has passed. We very much appreciate you making the time to come and give evidence today. It's been of enormous value to us.
Thank you.
The inquiry and the hearing today, so thank you very much.
Thank you, Eddie.
Thank you. Mr. Zammitt, thank you very much for taking the time to give some evidence today at this hearing. Before we start, could I just get you to state your name, your position, title, and swear either the oath or affirmation, please?
Yeah, thank you guys, for everyone for being here and for having me. My name is Alec Zammitt. I'm a publicist by trade and advocate for cannabis. For the affirmation, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Mr. Zammitt. Do you have an opening statement that you'd like to make?
Yes, just a very brief one, I guess, to give some context on where I'm going to be speaking from. I'm 31 years old. As I mentioned, a publicist by trade. I am a homeowner and a business owner employing staff. I have been a resident of New South Wales my whole life. I have over 10 years of lived experience with and around both illicit and medicinal cannabis. I am a prescribed patient, although I have not been required to use my medication for some time now, and I do not currently consume the medication. With this said, I still maintain my ability to access it should my needs change in the future.
Thank you, Mr. Zammitt. Some questions from the opposition.
Thank you, Chair. Thank you, Mr. Zammitt, for being here. So when you say you're an advocate for cannabis, just so I understand your position, for medicinal cannabis, for complete legalisation of all cannabis, what's the position you're advocating for?
For all of it, I do see a place for medicinal and for, I guess, for an adult use market where you could purchase it without a prescription. I started advocating for it prior to medicinal cannabis being available in Australia. I was operating businesses and contributing to society in a positive manner, in my own opinion. And I didn't like that I was being considered a criminal for my choice to consume cannabis at the time. And so, yeah, I started advocating for it. Since then, we've had medicinal. I think it's a great system that we have. There definitely are some flaws within the current system even, and we definitely haven't gone far enough. And something where you can walk into a retail store and purchase it is a lot more in line with where I see.
And your personal cannabis use, that was self-medication for medicinal purposes or recreational or both?
I don't quite see a difference between recreational, which I can get into a bit later. I feel that everyone consuming cannabis has underlying medical reasons to do so, even if they don't identify that themselves. They may think they're consuming it recreationally. I definitely was self-medicating, and yeah, now I'm prescribed it.
We've heard some evidence, I don't know whether you're aware of this, we've heard some evidence this morning in particular about concerns about conflating medicinal and recreational use because of the particular profile of certain types of medical cannabis products to treat particular types of medical conditions. Do you share those concerns, or do you sort of think all cannabis should be seen as interchangeable?
I think we have. I think all cannabis is interchangeable. You might have a stronger potency of a certain type of product. You can just consume less of it. If you have a lower potency, you can consume more of it. For the most part, and for everyone I know who consumes, it's quite easy for them to regulate their own use in a manner that works for them. By separating adult use and medicinal use, we're going to free up the medical professionals' time to be able to focus on the people who do actually need the help. We can redirect funds that are being spent on fighting the crimes that will no longer be crimes into education and harm reduction facilities. So if people do become dependent on it, they have other outlets to go to, which is already required at the moment. But I think it would definitely be beneficial to free up those medical professionals' times and weed out the ones who are just in it for a quick buck and not really providing the medical guidance that some people might be looking for.
You indicated that you were advocating for legalisation or increased access for adult use. Bearing in mind our experiences with underage drinking, underage smoking, if cannabis was to be a fully legal product in New South Wales, how do we prevent underage cannabis use?
I think the same way that we do with cigarettes or alcohol. I think that as the stigma around cannabis is changing, it's actually becoming less appealing to kids. I think a percentage of the appeal was the fact that it was illegal and maybe something that they were doing that was naughty.
Have you got any data or any research that supports your claim that there's reduced use of cannabis in New South Wales?
That's just my own personal perception.
Right.
Is
okay.
that the appeal from children is potentially, I guess, lower. I mean, I speak with my own nieces and nephews and family that I know that are of a younger demographic, and there just is no appeal to it, which I know that when I was younger, it was everywhere, and it didn't seem to really be causing much issues for the kids around me that were smoking, and I personally started consuming it at a young age, and I don't feel that negatively impacted me.
You acknowledge that we have a problem with underage drinking, so if we do exactly the same with cannabis, we're likely to have a problem with underage cannabis use, aren't we?
I'm not acknowledging that we have a problem with underage drinking. I'm saying that we could potentially treat it in the same way and try to prevent underage abuse of the product in a similar way.
Have you got any research which demonstrates that we don't have a problem with those under 18 drinking in New South Wales?
No, I'm not saying we don't. I'm just saying that I'm not saying that we do.
Okay. All right. Thank you. We've discussed a lot the issue of driving while impaired. There's a range of substances which can cause impairment. It's commonly accepted that cannabis is one of those substances. How do we, if cannabis is legalised, how do we go about regulating driving? Is there a safe level like alcohol? What's your understanding of that issue?
No, I agree with what Dr. Nicoletti, who was on before me, had said about most of it. One thing I do want to point out, though, is no one that's advocating for the driving legislation to be fixed, at least even for medicinal cannabis, whether we talk about non-medicinal cannabis as well, but no one is asking for the legislation about driving whilst impaired to be removed. That will always be maintained. That is applicable to if you're driving while drowsy just because you're sleep deprived or because you've been consuming other prescription medication like endone. That will always be there. It'll just bring, at least on the medicinal side of things, bring it in line with all other prescription medications. Now, we have that case study in Tasmania. Tasmania's had medicinal cannabis available to them for the same amount of time as mainland Australia and as we have here. The way that their laws are constructed, they have always had that defence available to them, that if they were a medical patient, they had a defence to the charge of driving with THC present in your system. They would obviously can still be charged for driving whilst impaired if impairment was observed or if an incident had occurred. And we haven't seen any detrimental effects to their road toll.
So you're suggesting that rather than a blood measurement, we should be looking for an impairment test, like the old walk the straight line with your finger on your nose, that type of test?
Potentially that, or even just if impairment is observed. I mean, currently, how do we police if someone hasn't slept in many days because they've been stuck on long hours at work or haven't been able to sleep for whatever reason, and they're now driving whilst impaired? We have that legislation there. There's the police are trained in how to identify those. I imagine, especially highway patrol, they can just supply it in the same manner as they would for any other medication.
And without any objective criteria, are we then relying on individuals to be able to assess themselves whether or not they feel impaired when they get behind the wheel of a car?
It would be the same as all other medications, so I guess that would be the
But
case.
with alcohol, we have objective guidelines, and so people will go, I've had 2 drinks, I won't be driving. Where is the objective criteria that helps adult cannabis users self-regulate cannabis use and driving?
All consumers that I know are rather responsible and can determine if they're impaired to do so and wouldn't get behind the wheel. I don't think it is in a similar basket to alcohol in terms of those benchmarks not being set. So I guess my response would be similar to what Dr. Nicoletti said previously.
So if I understand you correctly, you're arguing that cannabis users are more responsible drivers and road users than alcohol users?
No, not necessarily. I'm not comparing the two. I'm just saying that...
Sorry, I understood that's exactly what you were just doing. Yeah.
No, not comparing the two, but
Right,
they're both.
okay.
I'd say they're responsible. They are capable, just like consumers of all the other prescription medications that can cause drowsiness. They're capable of making an informed decision on whether they'll be safe to
All right.
get behind a motor vehicle.
Thank you very much.
Mr. Zammitt, do you think it's the case that there are some people out there who are accessing medicinal cannabis because they want to avoid, they're getting a prescription because they're avoiding criminality. They want to get a prescription so that they don't have to buy from the black market. They're adult use, recreational users, but they're getting it from the medicinal cannabis prescription pathway because they're concerned about being prosecuted for cannabis cultivation, possession and use.
Well, getting a prescription will not relieve you from any criminality in terms of cultivation, unless you're in ACT, which a prescription becomes irrelevant. In terms of possession and use, everyone I know, when I assess their situation and why they're consuming, everyone I know who consumes, which is a very large number of people, they all have underlying medical reasons for their consumption. I don't really know anyone who consumes in a recreational manner.
Alone, so it's like an intersection of both. There's a convergence of sort of recreational, it's a relaxational thing, but it's also got a medical element as well.
Medical benefits, yeah. And a lot of those people are consuming from the black market still. They're not under a prescription, so...
And in your experience, you're a resident of Western Sydney, is cannabis use pervasive? Is it normal in society? Most people have done it. Is it just part of the sort of fabric of society in Western Sydney?
Yes, definitely, and I think that that's true for beyond Western Sydney. I think that's true for a lot of areas and places I visit, out to the northern suburbs and the eastern suburbs. Cannabis seems to be very prominent throughout all socioeconomic classes and all walks of life.
And I'm not asking you to name anyone, but it's readily available. The policing hasn't really restricted its availability.
No, not at all. It hasn't been restricted at all. It is readily available throughout Australia from my own experience.
And do you ever see, like, have you ever heard or experienced like a decline from the black market? Heard of people talking of a decline in availability because of policing, or a particular like event has meant that there's been a drought of illicit cannabis?
No, I guess maybe COVID and the stay-at-home laws may have made things slightly more difficult, but I don't believe that there's really been any major impact from policing of cannabis specifically that's restricted the flow or ability for anyone to obtain it. And
do you think that people that use medicinal cannabis, or an intersection between medicinal cannabis and recreational cannabis, can lead productive lives, can be contributing, contribute to their family, their workplace, their society?
Oh, 100%. I purchased a home whilst I was a consumer. I employ people and operate my company. I guess I currently don't consume, so I'm capable of making that decision of when it is helping me and when it isn't helping me. I feel like a lot of consumers are in the same boat as me, and they're being unfairly victimised by the current legislation.
And when you say that, you mean the roadside drug testing laws?
That is a big factor of it, but also just possession, the fact that they're forced to go down an expensive medical route, and they're potentially not even able to grow their own. I think home grow, retail sales, and the driving laws are all elements that could be fixed.
And do you think that the price point for medicinal cannabis, the process you've got to go through, the price of it could force people back into the illicit market?
Yes, so the problem you've got with it, the way it currently is, in the illicit market you have people that are in it just for quantity over quality and just looking to make a buck, and then you've basically got the same thing over on the medicinal side of things. So because of such poor and such strict advertising restrictions placed upon the medical industry, they can't advertise to people that are already consuming black market cannabis that they offer it, they have it available, and the type of service that they can offer. So you're stuck with a bit of a process where you have to shop around with doctors to find someone ready to provide a suitable guidance that you need. So you may pay a high consultation fee and see a doctor that's just ready to write your script and send you on your way and doesn't necessarily want to go through a long process of actually discussing your needs and providing suitable guidance for your consumption. Or you might find one that goes over the top and does do that. You may pay a low consultation fee and be forced to take certain types of medication which is at a higher price, where you could have something of similar potency or slightly different at a lower price, which is still perfectly acceptable for your need. You just adjust the dosage you're taking, for example.
That's a really interesting point. So you think that the restrictions on advertising in terms of medicinal cannabis is limiting the amount of knowledge or understanding people have about the services that a practitioner may provide, and the consultation, but also the medicine that they may be prescribing.
Yeah, the availability of the medicine, 100%. So the advertising is laws and rules are restricting education being provided, and it's relied upon people who don't have an industry interest in the situation to provide that education. Whereas if the people who were the ones actually prescribing it and making the money off it and things like that, they could be a lot more forthcoming and provide that education there so people know. I mean, I still meet a lot of black market consumers who didn't know that medicinal cannabis is available to them. Some of those people have a barrier of entry due to the cost. Others, once they find out it's available to them, they head on and do it the right way and go through the proper process and obtain it that way.
Thank you, Mr. Zammitt.
Thanks, Chair, and thanks, Mrs. Zammitt, for coming along.
Mr.
It's
Lawrence.
much appreciated. I recently watched your interview on the new podcast Into the Weeds that's hosted by the Chair, Jeremy Buckingham.
Available on iTunes.
Hope you liked
Available on iTunes, I just heard,
What
and
is
YouTube.
shameless?
And I wanted to ask you a few questions arising from it because I did find it really interesting. And I remember on it that you talked about growing up in Western Sydney.
Yep.
I wanted to ask you, arising from that, what, to your observation, have been some of the harmful effects of the criminalisation of cannabis, particularly on your peer group when you were growing up in Western Sydney?
So I personally was lucky. I didn't receive any. I've never been charged or really had any negative interactions with authorities in relation to cannabis, apart from recently as a prescribed patient with 2 instances of driving offences or it being detected in my system. But when growing up and purchasing from the illicit market, I never really had an issue. Some of my peers haven't been so lucky, and I do attribute it just down to luck. So if you do fall foul of the law, especially if you aren't well presented or from a higher socio-economic class, or potentially, for example, if you're Aboriginal, there's a much higher chance that you will be prosecuted for a possession of a small quantity, for example. You then get stuck in a loop. So having that conviction on your record will limit your opportunity to gain good employment. And that could force you onto further criminality and other means of obtaining income, because the law has restricted your ability to assimilate into normal society.
Yep. So when you were growing up, did you have friends who were charged with possession of cannabis or supply of cannabis?
Yeah, I know people who have been charged with both.
Yep. And did you have friends who might be stopped and searched on the street on account of suspicion of possession of cannabis?
Yes, yeah, definitely, and that has also happened to me. So whilst driving, there's been many occasions since the driving with it present in my system was detected. Many occasions where I was pulled over and searched, and none of those occasions ever resulted in any offences.
And to your understanding, was that happening to you because your name had basically gone onto the database?
Yes, I believe so. And the number plate was entered into an automated recognition system. So once I changed the vehicle I was driving, haven't had an issue since then.
And to your observation, these young people that you knew growing up that were having those interactions with the criminal justice system, was that a positive or a negative experience for them in terms of how their lives then progressed?
It's definitely a negative experience. It can also be costly, both costing you money on legal representation if you do choose to obtain that, and the limitations it then poses on assimilating into society further once, if we're talking at a school age, once you leave school and start seeking employment.
Yeah. And did you notice were some people more affected than others by those experiences? So people maybe from certain backgrounds were more affected, less resilient, any sort of dynamic like that?
Yes, definitely. So I know people from very wealthy and affluent suburbs, so then I also know a lot of people in Western Sydney and further out west than where I am. It definitely seems that the lower socio-economic class and different minority groups or different racial backgrounds are targeted more heavily.
Yeah. Something that concerns me about the current regulation of cannabis in terms of the medicinal scheme is that we're in effect creating a two-tier system. One system for people advantaged enough to get prescriptions where they're exempt from the criminal law, irrespective of whether they're actually using it for recreational purposes or medicinal purposes. And then another tier system for those who maybe don't know about the medicinal scheme or don't have the means or wherewithal to access it, where they're subject to the full criminal law, which might impact on them differently depending on who they are and their circumstances. Is that something that concerns you? And if so, could you maybe expand on your thoughts on it?
Yeah, I 100% agree, and it is something that's concerning. The cost is a big barrier to entry, and just knowledge and education around the topic and knowing its availability is another example of some shortcomings that feed into that.
So when you were growing up, did you sort of get any knowledge or instruction about the interaction between cannabis and other prescription drugs?
Not necessarily. I didn't really consume much other prescription drugs when growing up. From time to time, throughout my youth, I was prescribed ADHD meds and sleeping tablets. Cannabis was able to replace those in my later early adult life, and now I don't consume any medication whatsoever.
So we took some evidence earlier in the inquiry from sort of people on the medical side of things that were very concerned about the interaction between cannabis and prescription drugs, and were making the point that that people getting medicinal cannabis should get that advice from doctors and so forth. And I asked a few questions about what's happening to all the people accessing it, the millions of people accessing it through the illicit market, who might not be getting that advice at all and might not even be aware of it and might actually be less likely to seek it out. And I'm just wondering, when you were sort of growing up and in the milieu that you were in, do you think those young people had access to advice about the interaction between prescription drugs and cannabis?
No, the stigma is changing, and along with the stigma changing, there's a lot more education available. Even on the illicit side of things, you have a lot of knowledgeable people who aren't just looking to make a quick dollar. They're passionate about the plant, and they're passionate about helping people. Different people for different reasons as to what they're passionate about, what type of consumption. But I've found that even on the illicit side of things, there is a lot of support and a lot of knowledge and a lot of guidance as to what is a positive way to use it and how it should be used. And I think that when looking at regulatory changes, it's important that we don't eliminate those people. So a lot of the people who are very passionate about the plant and have a lot of the lived experience and the knowledge about how it should be used and the best way to grow it and all those other things, a lot of those people would probably have a criminal record, and then so we heard earlier the ODC does criminal police checks, for example, when issuing permits and licensing, and so that's potentially eliminating some of the best people in Australia that we have for the job. So that's something that should be thought about and addressed when making these changes.
Yeah. So do you think that the existence of criminal offences for possession and cultivation creates obstacles to people getting the information that they need, particularly when they're young?
It definitely did in the past. I think, now that the conversation is changing and the rest of the world is moving towards a legal market, that education is becoming more abundant. But the laws definitely do hinder that.
Yeah.
And even in terms of the medicinal side of things, we have strict regulation around how the companies can advertise, and that poses that's a big hindrance on education getting out there further.
So we've taken evidence from the Australian College of Psychiatrists who, in summary, said that if you're smoking cannabis daily and you're under 15 or 15 or under, that your risk of psychosis is much elevated. What do you think is the best way to stop young people in those age categories and young people generally from smoking cannabis or consuming cannabis? I
think education and having a legal regulated market, as long as it's regulated in the right way, that would reduce it. For example, by allowing retail stores to open, we're taking money out of organised crime, and that would start to subside. So most of the suppliers for cannabis would either be medicinal or legitimate business, and they're unlikely to provide it to children, just like you see with tobacconists and things like that. On that note, we don't want to do it in the wrong way. If we tax it too high, for example, we'll fall into the same mess that the tobacco industry has fallen into and the vape industry, where you're just feeding it and handing the money straight to organised crime and encouraging that market while facilitating it, because they can sell from a retail store, and it's all still illicit. We need to make sure we really hit the nail on the head with how things are done in terms of providing licensing and permits that are required, and how much tax we put on it. But I do think that taxing it is a positive thing, so that we can put more into education and harm reduction for it has a lot of medical benefits, but it's definitely not for everyone. So if there are people presenting with psychosis from it, for example, which I don't know of anyone who has had that happen to them, and I know of a lot of consumers, then we can put some of the funds, we can redivert that to those professionals who would be dealing with that.
So the other factor that we've taken some evidence on in terms of eliminating a black market is distribution. So how it's sold and where it's sold particularly. And we've taken evidence that that one way to eliminate the black market is to ensure access very broadly. So you'd need to have distribution in small communities, in big communities, not just in particular suburbs, et cetera, et cetera. Have you got any thoughts on what the best retail model would be? I know that in parts of Canada it's a government-owned dispensary, and the government takes the responsibility of making sure the dispensaries are in lots of places. In other American states, for example, it's essentially private enterprise and they can set up anywhere. Have you got any thoughts on that issue of access?
I think to some degree it should just be treated like any other herb or vegetable, really. You register a business, you pay tax on the relevant tax class for the product, and then you operate. As for further regulations, they can be implemented, such as not selling to someone under the age of 18, and then we have the businesses follow that legislation, and punishments implemented if they don't.
Yeah. That's my questions. Thanks, Chair.
Any others from the government? No. All right. Well, thank you very much, everyone, for the questions, and thank you very much, Mr. Zammitt, for your advocacy and for your evidence today. We very much appreciate the perspective you've brought to the hearing and to the inquiry generally. So thank you very much, Alec.
No worries. Thanks for having
I
me.
did have one more question, actually.
Do you? Yeah.
Sorry, if you don't mind.
Yeah, fine. Fire away.
I was wondering, Mr. Zammitt, could you tell us about a bit of your interesting activism in this space?
So we run a campaign under the title "Who Are We Hurting?", which I guess is a self-titled question, just to ask who is actually being affected by people that want to consume cannabis. So in turn, that also relates to people cultivating it and distributing it. And so far, we can't really find the victim. The only victims seem to be from the legislation itself, not from anything to do with the actual plant outside of legislation.
Okay, and what other sorts of activism have you been involved in?
So the types of activism we do are basically just peaceful public activations that don't impose on the day-to-day lives of people. I guess as an example, we projected something onto the Sydney Opera House, which doesn't stop anyone from getting to work or living their day-to-day lives, but also conveys a message that we do want change, and the question of who are we hurting as cannabis consumers.
Thank you.
Seeing we've jumped in. Mr. Zammitt, I'd be keen for you to tell the committee what you believe is a difference, for example, at a big street festival where it is predominantly alcohol and people are drinking alcohol compared to, for example, let's say Mardi Gras Nimbin, or a festival where people are largely consuming cannabis. What, from your experience, will be the difference in terms of interaction, the way people behave, behaviour, particularly from men, let's say? If you could just...
Yeah, so I guess from my own experience attending festivals where there's bars scattered all around the place and the prominent substance of choice is alcohol, I guess you tend to see a lot of fights and violence and unsavoury types. I guess when I attend Nimbin Mardi Gras, there's a large demographic of different types of people of different ages and different social backgrounds, and everyone seems to be quite friendly and get along with each other. You don't see any fights, and I guess it's just a much more pleasant experience all around.
So cannabis generally doesn't make people want to, get involved in street brawls?
Yes, definitely not. If anything, it would help stop them.
Thank you.
Thank you very much for those questions and that contribution, Mr. Zammitt. Really appreciate you coming along, giving your evidence and your perspective to the inquiry. Thanks very much, mate.
Thanks for having me. Cheers, guys.
Thanks very much. Thank you, colleagues. Well, that draws to a close the morning/early afternoon session. We'll now break for lunch and return at 1:45 p.m. to hear from the Centre for Road Safety and the cops. Toxic masculinity.
So you get too much of the member.
The video. We'll have to cut that out. Afternoon, everyone, and welcome back to the hearing into the inquiry into the impact of the regulatory framework for cannabis in New South Wales. Thank you to our witnesses, Mr. Carlon and Ms. Higgins. You do not need to be sworn because you have already been sworn before this committee during this inquiry. So thank you very much. Would you like to start by making a short statement?
Yes, thank you for inviting us to appear again.
Thank you.
I'd like to provide the committee an update on our drug driving research and analysis since our last appearance. These steps are consistent with the New South Wales Government commitment to actively monitor this issue. Since December last year, we have progressed and are now finalising a study into the knowledge, attitudes and behaviours of driving after taking drugs, which includes a survey of over 5,000 drivers. Transport understands that many users of prescribed cannabis medicine are using their medicines appropriately and are not risking drug driving. However, among those who reported using prescribed cannabis in our research, 54% did not use it as prescribed. This includes the use of recreational purposes or at a higher dose or more frequently than prescribed, or using medically prescribed cannabis without their own prescription. Among those who reported using prescribed cannabis who had their own prescription, nearly 40% reported using illicit cannabis some, most, or all of the time in addition to their prescription. Around 4 out of 5 said they were advised by a medical professional not to drive after using medically prescribed cannabis. Of those who had been advised not to drive, 45% had driven within 6 hours of using medically prescribed cannabis, which may well be while they are impaired, noting medical advice that impairment typically lasts 3 to 8 hours. This highlights one complexity of providing what may appear to be a simple solution for people taking medically prescribed cannabis while managing safety outcomes for all road users. Most of the published research on cannabis and driving has focused on recreational use and has found around a 40% increase in crash risk. The crash risk from medical cannabis is less clear, but there is no scientific consensus on an acceptable THC level in blood that indicates the degree of impairment and crash risk as there is for alcohol. There has been no change in this overall position since we last appeared before the committee. We've also provided more information from our crash data to the committee. We advised that there were 241 drivers or motorcycle riders with the presence of THC involved in fatal crashes between 2019 and 2023, and that 120 of these, that is half, had no other illicit drug present or illegal levels of alcohol. This means about 8% of fatal crashes over this period involved a driver or rider with the presence of THC only and no other illicit drugs or illegal levels of alcohol. To supplement our own analysis, Transport has commenced procurement of an independent literature review into cannabis and driving with specific focus on medically prescribed cannabis and approaches in other countries. We are regularly in contact with Victoria about their closed track trial, interim legislation changes which point of prescription information, which was enhanced in March 2025. That point of prescription information, we're liaising with Victoria to adopt that in New South Wales. Thank you for this opportunity to provide an update, and we are pleased to take your questions.
Thank you, Mr. Carlon. Mrs. Carter.
Okay, thank you, Chair. Thank you very much for being here. And apologies, I'm conscious that you've presented evidence before. I wasn't on the committee at that stage, so if I'm asking you old questions, feel free to tell me you've already answered them and we can move on. So if I understand you correctly, the update you gave us, you said that most medical cannabis users were using the medication appropriately. Could you tell me what you mean by using it appropriately?
Well, in the research, many of those prescribed cannabis users were using it according to their medical practitioner's advice.
Right.
What we've clearly then discovered in that survey that
54% were not using it as prescribed?
54%
Right.
did not use it as prescribed.
Right. And was using it appropriately, did that relate to driving afterwards, or that was just using it as prescribed?
So we would say in accordance with the script, and that would be in accordance with any advice the medical practitioner had given them not to drive.
Okay.
Yeah.
And your understanding would be that a medical practitioner may say avoid driving for 8 hours. Would that be your understanding? Or?
The current health advice in New South Wales is not to drive whilst taking medicinal cannabis.
Right. Not to drive. Yeah. Okay. Thank you.
At all.
Yeah.
That's my understanding of the current advice from New South Wales.
Like not during a period proximate to ingestion, or just at all, don't drive ever?
My understanding is the health advice is not to drive.
Through the period, like
whilst you're on the
Okay.
prescribed.
And are there other drugs? I believe there might be drugs, for example, with respect to epilepsy or something. Are there other drugs that you're aware of used medicinally where the same advice would be given not to drive while you're taking this medication?
Again, it's probably a question more relevant for health, but my
Right.
understanding is that yes, there are when medical practitioners are prescribing, there are occasions where they will say that you should not drive whilst taking this prescription.
Right. Thank you
Yes.
very much. And what strategies are currently in place to deter cannabis-impaired driving? And are these the same as those for alcohol-impaired driving, or are they different?
So New South Wales, and most of the jurisdictions in Australia have adopted a mobile drug testing program, which is modelled on the drink drive program, which has been in RBT, which has been in place since the 80s, which has seen a significant reduction in the number of people who drink drive, and also those who've been killed in crashes involving drink driving. And that system is a broad-scale oral fluid roadside testing program, which identifies 4 illicit drugs, including detects THC. In New South Wales, the policy framework is in our Road Safety Action Plan to conduct 200,000 roadside drug tests. The evaluation of the Victorian scheme has indicated a significant positive road safety benefit in the roadside drug testing program, and we do have the information on the specifics of the number of fatalities and serious injuries that they have demonstrated that have been prevented as a result of that broad-scale roadside drug testing program, which is modelled on the RBT program.
Okay, if you could provide those on notice, I'd be very grateful. Thank you. And so the objective is 200,000 roadside drug tests. How are we tracking with getting up to that 200,000?
Yes, so indications are New South Wales Police last year actually delivered just over of those 200,000 tests in New South Wales.
Great, and so that's the annual target then, is it?
Yes.
Great, thank you. And then the data from those, who collects the data and on how many drug detections there are?
So New South Wales Police conduct the tests.
Right.
Certainly we share that information and that data on the detection for that program as well, and it's around 50% of the detections are THC detections. In my understanding is around a quarter of those, like there are poly use, so we do get the detection of THC with the other drugs that are being tested for in the program. And so, yes, THC alone, we also have the data on how many are just THC detections.
Provide that on notice, that'd be great. And the drug tests are also alcohol tests?
Yes, so generally police would conduct an alcohol test as well. From our point of view, in terms of the fatality crashes, we would see around 25% of the detection of THC in fatal crashes includes alcohol. And it's around the same for methamphetamine, around 25% of those crashes would include both.
Right, okay. There's been some discussion in evidence this morning about other prescription drugs that can affect driving ability. Do you have any information about how THC-based impairment risks compare with those of other prescription drugs which can affect driving ability?
Look, I might just make an initial statement and hand to Louise for this one. What we do understand is the recreational use of cannabis is at significantly higher levels. So the illicit use of cannabis, significantly higher levels than the illicit use of other prescription drugs. And as you would have heard from our health members this morning, the regulatory regime and the approval process for those prescription drugs which are TGA approval, have much more robust systems in the management of those drugs, whereas the special access scheme for the currently more than I think 750 medicinal cannabis products, it doesn't go through that same degree of robust analysis by the TGA. But I'll hand to Louise for more detail.
Thank you.
Thanks, Bernard. I think just in relation to the crash risks that are associated with other prescription drugs, there are definitely, and repeated research studies have found that there's elevated risks associated with misusing opiates, with misusing benzodiazepines, with mixing those substances, particularly with alcohol. That definitely elevates the risk of a crash or of a driver being culpable in the event of a crash. So there's certainly risks associated with those drugs. Those drugs can be enforced at the roadside where a driver is deemed to be under the influence under our current laws. So that is distinct from the presence regime. But I just wanted to clarify that there is a way for prescription drugs to be enforced under our current law, and that there are risks associated with those drugs too.
Do we have any data? I mean, I think you said, Mr. Carlon, correctly that there's probably more cannabis users than prescription drug users. Do we have any data about how many driving incidents were caused by presence of THC compared to opioids or benzodiazepam?
Yes, so again, I might get Louise to respond.
Sure.
Yeah, look, I think not in the same way. So we don't currently have an aggregated number that indicates where we see particularly benzodiazepines or opiates in the drugs. The data is there, but it does require us to have a framework to look at it. So benzodiazepines is a class of drug, and there's various drugs that fall under that regime. There is some complication because some benzodiazepines can even be administered to someone, or opiates for that matter, after a crash, and it can sometimes be caught up within the post-crash data that we have. So in terms of pulling out those numbers, it is a more complex task. In terms of identifying the substances in themselves and then identifying, how and why they were present, and then looking at the levels of those to see whether they were associated with a crash. So we don't have nice, clean, aggregated numbers around those substances.
Right. Okay. Thank you.
And just to clarify, and so I was referring to the National Household Survey on drug use, where 11% of people had reported taking cannabis in that year 22 to 23, whereas the illicit use of pain relievers and opioids for non-medical purposes was 2.2%, which had reduced since 2016, where it was at 3.6%.
Okay.
Do we have the numbers? Sorry to jump in there. Do we have the numbers for non-illicit use of opioids?
No, sorry, I don't have ads here in front of me.
So that was for illicit use of opioids?
Yes, that's correct, yes.
Not prescription opioids or...
Look, perhaps my last question, if as I understand you correctly, a target of 200,000 roadside drug tests is acting as a deterrent on driving after cannabis use, if there was to be a regulatory change that might perhaps see more people using cannabis, so some form of legalisation or decriminalisation, what extra resources do you anticipate would need to be deployed to keep our roads safe?
Look, there is modelling work that has been done around the levels of roadside drug testing by Monash University and the optimal sort of road safety benefits from different levels of testing, of screening testing. Certainly in that context, I mean, we would need to do the work to determine what sort of risk or additional risk there is. That said, and again, Louise can confirm, the research on legalisation in other jurisdictions has indicated a slight increase in road crashes and road trauma, where that's been implemented in other jurisdictions internationally. And so we would look to that sort of research in order to make that sort of assessment, I would imagine.
Right. Do we collect data on road crashes by police district or by geographic area or just whole of New South Wales?
The data that's collected from crash reporting, reported to us by New South Wales Police, is at every is geolocated at every site,
Right, okay.
and that data is aggregated in all. It's provided to local government based on their local government boundaries, right down to we publish those crashes on our website, actually at the street level.
Right.
All that's publicly available as well as being available in open data.
Is it possible on notice? I'm aware that at an estimates hearing, the New South Wales Commissioner of Police expressed a concern about the Southern Command and anticipated additional crashes after the liberalisation of the ACT drug laws. I wonder if we have any data that indicates that that fear was actually made out.
Not to my knowledge.
Okay, right. Okay, thank you very much.
A couple of questions. If 4% if the National Household Drug Survey is showing that 4% of people are using annually illicit opiates, and opiates generally can be a significant issue in terms of impairment and road safety, whether illicit or prescribed. Why do we not test for opiates in RDT?
Yeah, so just clarifying, that was 2.2%?
2.2%.
Yeah.
So,
and certainly, those drugs are tested for in terms of impairment, and so the driving under the influence, I suppose, is a historical context where...
but they're not tested at like roadside drug tests.
They're not. No.
A swab.
No.
So they're tested in terms of impairment.
Absolutely.
If a police officer believes you're impaired, that they can
arrest you for the purposes
of that, and then a blood test.
Yep, and that offence is the equivalent of a high range drink driving offence.
Exactly. And how do they establish at a roadside? They establish you're impaired on opiates.
So it would be the manner of driving, which they would have observed, and any other physical characteristics of the individual in the vehicle. But there are police procedures which clearly they would be better to respond to, but within the law, the manner of driving and the appearance of the individual, which indicates some level of impairment, provides them the opportunity then to conduct a sobriety assessment.
But again, why do we not test for opiates, illicit opiates, in RDTs?
Again, I'd say because it's come from a history of being a regulated drug, a medicinal drug, and it hasn't, from our observations in the road trauma data. The two significant drugs that appear in the road trauma data are THC and methamphetamine. And
amphetamine.
Yes.
Alcohol though as well.
Louise might like to add.
Yeah, if I can just add, as I highlighted, we currently haven't looked in depth in terms of aggregating the impact and the prevalence of, say, benzodiazepines in our trauma, as well as opiates. So there's definitely, it's an area that we've identified as needing further work, because raw data does sit there, and there is a need for us to do further analysis of that piece. So we are looking at providing a framework for looking at those drug classes that would enable us to then better understand the extent to which opioids and benzos are actually contributing to the trauma problem, and which may then justify some reform in that space and a different approach other than the DUI approach, which has applied for a long time.
Of the you said there was 240 road fatalities, I think you said, and 120 where cannabis was present, in a post-mortem to some extent, and there was no other illicit drug. Of those 120, how many had some form of prescription drug?
There will be some. We have not distinguished out whether some of those drivers may have had aside from those illicit drugs, they may have had a prescription drug, either at a therapeutic level or a misuse level.
How come we don't have that data?
Because we haven't got that framework for distinguishing out whether that drug was there for a therapeutic or a non-therapeutic reason. These samples come generally from when a person's injured in a crash, so they're taken in a hospital environment where a range of, if the person's alive at the point, a range of pharmaceutical drugs may have been administered as part of their treatment, noting that patient care is the priority before the samples are taken for the purposes of our Act. We were talking about like fatalities.
Fatality.
These are drivers.
Medicine.
These are drivers and riders involved in fatal crashes. So some of them will have died. That's right. So that their samples will not have anything obviously administered post their death. Others are people that are still alive.
So these figures would capture people who weren't at fault in an accident.
That is true. They may. Yep, because it's all drivers and riders involved in fatal crashes.
Yep. You got anything, Kate?
Yes. How do I start with this? With the, let's say, opioids. So, for example, somebody is involved, and this is kind of relevant because we've got, we're looking at a bill, of course, that's coming before the Parliament that's going to extend the testing for illegal drugs for people who are in accident that cause grievous bodily harm, not just fatalities. So I think it's quite relevant to consider in that way. So when people get tested, say in a fatality, does the quantity of the drug, so for example, they have a super high rate of a certain type of opioid in their system, super high level, I should say, in their blood, compared to a little trace of an opioid that they may have taken according to prescription 15 hours ago, because they understand oxycodone, for example, can stay in your system. I've got it here from anything for up to 20 hours, but it can also turn up in drug tests up to 90 days, according to some things that I'm seeing. So is that tested for firstly? Does someone, for example, could have a tiny little trace of THC in their system, or they could have much more?
Yes. So that does provide a concentration. So there are analytical cut-off levels that our colleagues at Health can talk about, but are there to ensure that we can have certainty that the drug is there and is at that level, but it can find low levels of all drugs, be they illicit or illicit.
And who determines, is this if it just goes to a court, but the determination around the level, because we see the stories about somebody having, a very high blood alcohol level, for example, and we all go, wow, that is very impacted by alcohol. What are the cut-offs? What's the determination? For example, a particular level of opioids where somebody could say, gee, that is really impacting them. Do we have those levels for any of the prescription drugs, for example, or who does that determination? Yeah.
So there are no levels established within the law. However, once there's a fatality and the blood sample's analysed at our New South Wales Fast Health Lab, the results of that analysis go through to a pharmacologist at New South Wales Police for consideration of whether any charges should be laid. And so in any person's sample, you might have a mix of substances at various levels, and a clinical determination is made as to whether those particular substances, because you could have, up to many substances in a person's blood, whether they are there in a level that's consistent with a clinical or a prescribed dosage, or they may be there in a much higher level than that. So that is a clinical investigation and look at that blood level and the mix of drugs, because one particular drug concentration may not indicate impairment on its own, but if it's there with 3 or 4 other drugs or with alcohol, it may be that
Sure.
based on that expert evidence,
Thank
it's
you.
enough to indicate
So in
impairment.
terms of the statistics that you collect in relation to drugs and driving and the data that you provide, at this point, is it just when you're gathering fatalities, data around fatalities, is it just the illegal drugs that you have in terms of data, or do you have this person was found with in a fatality, opioids in their system, and that is collated and reported as well?
Those substances will be listed there in the sample record that comes across to
Like any
to
trace?
Transport.
Sorry, listed publicly? in
Not
terms of the
not
report?
publicly. It comes across. It's held in confidential information that we have in our drug database. So we have protocols around who can access that particular personal information that we hold.
That's the questions. It's just in terms of the reporting that Transport for New South Wales and the Road Safety Centre do in terms of the impacts of drugs and drug driving and fatalities. The drugs that are reported, the alcohol clearly is a drug. The other drugs are currently illegal, even though medicinal cannabis is legal. They are the drugs that are tested for. Is that correct?
They,
Or are
in
there
addition
more?
to others as well. They're the ones that we report on because we have a framework around those four
So that's the key
prescribed
question I'm asking,
illicit drugs.
the reporting.
That's right.
So
We don't report on the others.
You're
and
testing for others, for example, benzos, other things, but they're not in the drugs and fatalities, drug driving. That's not reported.
That's right. Not
Even though
systematically.
what is being reported is partly illegal.
We can't differentiate the
I'm aware
THC
of that.
records
That's
from recreational use and medicinal cannabis. That's
How
not
do you
possible
differentiate
either.
between opiates, between
Exactly.
illegal, like unprescribed benzos and prescribed benzos? Because you can buy benzos on the black market, you can buy heroin, and you can. How do you differentiate between when it comes to opiates and benzos? in
Yeah,
your
so
reporting?
again, the pharmacologist is making an assessment of the information that comes from blood tests that actually collate all drugs that are being tested for, and they prepare that in terms of evidence for an offence. As Louise has pointed out, she might want to just recover this, because of the complexities of the administration of drugs in that post-crash period. We haven't done the analysis of separating out those particular drugs at this point.
I've just got one more before I hand over to the government, and that is there's some legislation. I can talk about legislation before the House, can't I?
Yeah.
Yep. The post-crash drug and alcohol testing legislation, the Road Transport Amendment. There's an absolute liability if you're on any form of THC whatsoever, you should never be on the road. That's the current situation, either prescribed or not. So with the post-crash drug and alcohol testing regime that's proposed, that if there's a serious accident where serious crash, where there's grievous bodily harm involved, there will be mandatory drug testing of everyone who's involved in that. And therefore, if someone was in an accident, they weren't at fault, they had trace levels of, and there was grievous bodily harm, trace levels of THC in their system, they are in serious trouble, aren't they? They've committed an offence. They should not have been on the road and could be culpable.
Yeah, so just to canvass the use of the word trace levels, so the laboratory,
any level.
I understand, has a cut-off level that it applies in the detection of all drugs in that context. Again, a matter for FAS, from New South Wales Health. But yes, an offence of a presence offence would be able to be detected if THC was present in the blood.
So potentially we're just about to expand the class of people who may be subject to the testing, and therefore medicinal cannabis patients who may have had medicinal cannabis a week before, but it turns up in their blood in an accident, not at fault, committing an offence.
Including cyclists.
Including...
So just to clarify, so in relation to cyclists, the presence offence that we have doesn't apply. So there is no risk of the proposed reform, which would extend those fatal and post crash fatal provisions to cyclists applying in that context. The presence offence doesn't apply. Just to provide a little bit more clarity, so the bill that's been introduced would extend the provisions that we already have for post-fatal crashes, mandatory testing to cases of crashes involving serious harm, consistent with grievous bodily harm. So it does not affect any of the offences under the Act. So it doesn't change the offences. And so, yes, it's an offence to have THC present in your system, and it will remain so. And this may provide another way that drivers could be identified with having THC in the system, and that offence could apply. However, we have had a closer look at our fatal data, because obviously this is something that already occurs, and the charges that proceed against a driver after they've been involved in a fatal crash. And I think it's important to highlight when we talk about fault and not fault, that we, within our crash data, we don't attribute fault or responsibility for a crash. So that's something that's established through police investigations, charges, and then the court processes. But we do identify a key vehicle in a crash, and this is generally the vehicle that initiates the movement that results in the crash. So it's not a direct indicator of fault, but it's a good proxy in our experience. In some cases, detailed police investigations can find that other parties in the crash that aren't the key vehicle also did something that contributed to the crash occurring. So it's not a perfect measure, but we have been able to further look at the charges that have resulted from fatal crashes in New South Wales. So you can get an indication of how frequently drugs presence is pursued as a charge. And really that does indicate that the drug presence offences represent a small proportion of the offences following a fatal crash. And they're typically in combination with another serious offence and involve the key vehicle controller. So over the 5-year period, 2019 to 2023, there were 238 drivers who obviously were not killed. They were convicted of at least one offence as a result of a fatal crash, and that was a total of 452 offences. So 90% of the offences following a crash are associated with this key vehicle driver, so not a not at fault driver generally. 71% of the offences for a key vehicle controller relate to serious offences involving death or serious injury, so not necessarily the presence offence. So that includes dangerous driving resulting in death or GBH, negligent driving resulting in death or GBH. Of the 238 drivers that were convicted with offences following a fatal crash, 38 were convicted of an illicit drug presence offence. That's over a 5-year period. Most of the drivers were considered the key vehicle and had concurrent convictions for more serious driving offences relating to the incident. So drilling down further into those 38 drivers, 24 in our analysis had an illicit drug presence offence with THC present, which is around 10% of the 238 drivers. And that THC may have been present with another prescribed illicit drug. So I guess in summary, while the law does apply, and in the event of a fatal crash, a driver who uses prescribed cannabis may be convicted of an offence, our data indicates that it's not currently a common occurrence.
All right, thank you. I'm mindful that I've taken up the time. Mr. Murphy.
Thanks, Chair. Mr. Carlon, earlier you spoke of roadside drug testing as a deterrent and described it as a success. How do you say it's successful, or what are you basing that on?
So most jurisdictions operate a very similar program. So Victoria's roadside drug testing program is similar to New South Wales. An evaluation of the Victorian random drug testing program, independently conducted by Monash University Accident Research Centre, found the system of the broad-based roadside drug testing directly comparable to New South Wales' approach. Had a positive impact on road safety. Specifically, their report found the expansion in roadside drug testing in Victoria from 42,000 to 100,000 in 2015 to 2017 has saved more than 30 lives and almost 80 serious injuries on that state's road every year. And the further increases in roadside drug testing.
Why do you say that's happened?
Well, they've done the analysis of the preventative effect of the roadside drug testing program in the same way that we've evaluated RBT over the years in terms of the reduction.
Yeah, that's
of
what I was
trauma.
going to ask about, because I mean it's quite clear from the evidence that the more alcohol you have in your system, the more impaired you're going to be. The evidence in relation to cannabis is quite different to that, where the roadside drug test is picking up potentially trace amounts that may not have anything to do with impairment or safety. And, we heard evidence earlier today from Mr. Zammitt, who described it, my memory is correct, as a lottery, effectively, where people are following their advice from their medical practitioner about how to use the cannabis that they've been prescribed, and some people are being picked up and prosecuted because they happen to come across an officer who administers a roadside drug test, whereas others aren't. And he described it as more of a lottery, but not something that was changing behaviour.
So clearly this research indicates that it has had an impact on trauma. Just to clarify, the roadside drug testing program is scientifically calibrated in order to detect recent use of THC, and there's a significant body of evidence that THC actually increases your crash risk by 40%.
Sorry, when you say it's calibrated to detect recent use of THC, what do you mean by that?
So it's an oral fluid wipe, and oral fluid, so THC is retained in oral fluid.
I know how that works, but a doctor may say to somebody, don't drive for the next 6 or 8 hours. They may drive, say, 10 hours later and still have trace amounts of cannabis picked up by that test.
And they're unlikely to be detected by the oral fluid device that's used in New South Wales because it has a cut-off threshold which only detects recent use, and by far the majority of people would be detected within that 8-hour window.
The majority of people?
By far.
But not everybody.
There may be.
There'll still be people who will have been using their medicinally prescribed cannabis according to the instructions of their doctor that will still be picked up, won't there?
Yeah, there has been a lot of the research of what we know about how THC is eliminated from oral fluid. So we definitely see after use a very significant spike in the THC levels and then quite a rapid drop-off in the oral fluid. So we do know that those peaks are associated with close after the THC has been, close after the drug has been used. Most of that research comes from clinical studies that have been done of people using a recreational drug, but there has been some research that's looked at what happens to oral fluid levels after a drug has been, after a prescribed cannabis medicine has been used. So Swinburne University did a study only last year, I believe, which looked at this, and it does show that you have the same pattern of a peak after use and then a rapid drop-off. And some of those levels, the peak is lower than what you'd get for recreational use, being consistent with the THC level for some patients not being as high. within the participants that were part of that study that looked specifically at what happens for a person with a prescription, there was significant variation. So it was a semi-naturalistic study. So participants were taking what they'd been prescribed. So those who were prescribed higher dosages presumably may have been those drivers, those participants who had higher levels for a longer period. That's right. However,
they're using it in accordance with their instructions.
That's right. However, most drivers in that study had dropped well below a detection level by 6 hours post-use, and we can provide that study to the committee if you want to have a look. Yeah.
So just to
and
be
they
clear,
wouldn't have been detected in a roadside drug testing.
So if someone is taking medicinal cannabis in a capsule form, there's no way that they can be detected an RDT.
I couldn't comment on that. I know there has been studies where they've looked at different forms of cannabis and how that affects the levels that you see
But
after
if
use.
the cannabis doesn't appear in your oral fluid, it's just in your blood. So if you take a capsule that you then ingest and then is absorbed in your gut and then into your blood, you're not going to be tested. You're not going to test positive in RDT.
I couldn't confirm that because pharmacology is not our area of expertise, but
It's not
I
pharmacology.
can say that it would be.
The test itself. So unless the THC ends up on your tongue, that's the only way it's going to be tested.
If there's contamination of the oral cavity with the THC, then there'd be at risk.
So therefore, if there's not, because when you have a capsule, the capsule itself isn't THC. You ingest it and then you absorb it in your gut. Therefore, you're not going to. You could have if you decide to take your medicine, like in a capsule form, you wouldn't test positive at an RDT. Is that a possibility?
I expect it is a possibility based on the science.
Yeah, the roadside drug testing program is measuring the THC in oral fluid.
So just a question from me, if I could. I think, Mr. Carlon, you said that over a 4-year period, that drivers involved in fatalities just with THC was 8%. Is that right?
Correct.
Yeah. If you, I'm not sure what the right word is, but if you sort of break that down for factors like age and gender, and then consider use of cannabis across the community, to what extent does that 8% figure, and I suppose the other figures where there's a mixture of THC and something else, to what extent does that figure speak to an elevated risk from cannabis? I'm just thinking about a scenario where you might have 8%, but you might have something like that across the community that are smoking cannabis, and so it just sort of turns up in the accident stats without necessarily of itself indicating an elevated risk.
So what we would say is that in those cases, there's the testing clearly is determined by the timing at which the person was, the bloods were taken in the test, and it's clear that in many of those cases they're at a level that would affect your driving skills. Yeah. So I'm not sure exactly.
So I'll put it a different way.
What your question is.
Like, if you assume that there's a bias towards young men in the fatality stats, for example, which I think there would be, there'd certainly be a bias to men. Are you able to say to what extent that bias has an impact on these figures? Like, if you randomly sampled 100 young men walking down the street, I'm just wondering what percentage would have THC in their system, and that's sort of relevant in considering the significance of these statistics. Is that being disaggregated, if that's the right word?
Yeah, look, we do have data on the age and distribution of the fatalities in this area as well, and whilst, yes, there's a sort of overrepresentation of males and also younger drivers, it is distributed across the broad age range as well. And certainly the rationale for the programs that we have in place is actually in relation to the impairing effects of the use of THC. And so the reason why we're focused on programs to manage and reduce the occurrence where people take THC and then drive within a short period of time after their consumption is that the body of evidence is fairly clear that that's an impairing period for driving whilst you're after you've consumed THC.
Okay.
Yeah.
And just one more question, if I could. You might want to take it on notice because there's not a lot of time. But in terms of the amount of fatalities where benzos or opioids of a prescription type are found in bloods, I remember reading Institute of Criminology stats and various stats from different sources that seem to reflect that those two prescription drugs were turning up, if you combine them, certainly turning up at a higher rate than cannabis. And I'm just wondering if you could sort of take that on notice and give us some information about how often they're turning up in fatalities blood samples, because I think you said, Mr. Carlon, that there's more cannabis use going on than prescription drug use, for example.
Illicit use, yes.
Yeah, sure, illicit use. But if I'm correct in my recall of those stats, which is that if you put them together, they actually turn up in more fatalities than cannabis, then I'm interested in what that says about this kind of link, I suppose, between accident and use.
Yeah, absolutely. We
We
have
can
a look at that
have a
data.
look at what we can provide. As I mentioned, we don't at the moment have a framework for looking at those substances. So there's obviously a lot of drugs that can fall within that benzos class, and some of them, because of a person may have taken their particular medication. And it may appear in a fairly low and therapeutic level. So I think it might depend on the study. If the study is just looking for the presence of benzodiazepines, then you may find that they are present there in a level that's consistent with prescribed use across the community of those particular types of drugs to some extent.
Yeah,
there would
I mean,
probably
I don't
also
think
be
so
misuse.
On the stats I remember stats like somewhere between 15 and 20% of fatalities had either one of those two, which would seem higher than general use in the community, I would have thought.
Yeah, look, the challenge for us without diving in and doing a detailed look at those cases is that we won't necessarily know without that advice from a pharmacologist whether it was there in a level that's consistent with a therapeutic use, where you wouldn't expect there to be an impairment if there was a stabilised dosage and a period of adjustment after, say, a prescription change or something like that.
Yeah, but if you're relying just on the statistics to compare the two, then you could say the same thing about cannabis, right? You won't know whether that was in the person's blood to a level that impairs. But it's still factored into the 8% that you presented us with.
That's true. We can look, and we have looked at a very raw level, at the level of cannabis that's in all those drivers that are appearing in our fatal crash stats. And I think it's fair to say we have provided some of this information on the records, actually in response to a parliamentary question from the chair. And I think you do see in those stats that there are fairly high levels of cannabis, of THC, to be correct, there in those drivers. So it's not necessarily only, drivers with a small amount from use a substantial period of time before. It's definitely there in an elevated level.
Yeah.
Thanks, Ms. Higgins.
Sorry,
just apologise. I think we ran over time, but thank you very much. With that, has to draw an end to that round of questions. Thank you very much for coming again to provide the inquiry and this hearing with the evidence. It's very much appreciated. It's going to be of enormous use in our deliberations. Thank you very much. Any questions on notice, the Secretariat will be in contact in due course. Thank you very much.
Thank you.
Joining us, Deputy Commissioner Hudson. you can hear us loud and clear?
I certainly can, sir. Thank you.
Thank you very much. Before we kick off, if we could just get you to state your name, position, title, and swear either the oath or affirmation, please.
Yes, my full name is David William Hudson, Deputy Commissioner for the New South Wales Police Force, and I'd like to swear the oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, nothing but the truth. So help me God.
Thank you very much, Deputy Commissioner. Do you have any introductory remarks or opening statement you'd like to make?
No, I don't, sir.
All right, thank you. Well, we'll start with some questions from the opposition.
Thank you,
Mrs.
Steve.
Carter.
Good afternoon. Thank you for being here, Deputy Commissioner. We're contemplating legalisation in this committee. How might that impact how might that impact police procedures relating to search and seizure, and what training would be necessary to adapt to any changes that we may recommend and Parliament may accept?
Thank you for the question. I imagine it's what legalisation looks like. If it's totally legalised, then rather than being decriminalised, then we wouldn't be looking for it because it wouldn't be a crime.
Yeah, fair point. Yeah.
So there's a variety of options available to your committee to make recommendations, I'd imagine. Training is something we constantly do. A variety of changes to legislation that are constant. We continually update our staff as to procedures, especially in relation to searching, especially in relation to seizures. If there's a legislative change, so if there is a change, then our compliance with that, I would suggest, would not be an issue if an appropriate time for training to be delivered.
Are you aware of other jurisdictions that have legalised cannabis and what impact, if any, that's had on the illicit trade in cannabis or organised crime?
I've had some experiences overseas, especially in the United States, where it's openly and freely available for purchase from shops in certain cities, New York, Las Vegas, San Francisco. Cannabis itself being decriminalised, there's a whole swathe of research that I read some time ago, and it is some time ago, that cannabis leads to other drugs. And I think that's probably revealed in some of the drug testing that Traffic and Highway Patrol do with detection of cannabis and a mixture of other drugs in individual systems. The experience of not the major cities of New York and Las Vegas have decriminalised cannabis. San Francisco has gone a bit further with other drugs, and so did Portland in Oregon, which led to some quite horrific outcomes, which have caused certainly Portland to reverse that decision and make it criminal again for drugs, but specifically for cannabis. I'm not aware of impact on those jurisdictions. It's more probably described as harder drugs that have had a major impact.
Assistant Commissioner Glenn Weir from Victoria Police told the Victorian inquiry into the use of cannabis that studies from overseas show that legalisation has not eliminated black market supply or associated organised crime. Would you share those concerns, or would you have a different view on the impact on the black market?
If any commodity is decriminalised, made legal, it becomes expensive in a legal framework as well, and we've seen that in some of the We've seen that in the tobacco trade. The illicit product is a lot cheaper than the valid legal product. So we've seen organised crime enter into that market. I've recently seen some evidence from one of our intelligence agencies that by next year illicit tobacco will be sold in higher quantities than legal tobacco in this country. And we've seen organised crime will take any opportunity, and we've seen that seeping into the tobacco trade. Any opportunity to make profit, if decriminalisation leads to or legalisation of cannabis leads to opportunities for organised crime, they will certainly take it. And that has been the evidence that we've seen historically. That's the evidence we've seen overseas. That's the evidence we've seen here with tobacco at the moment and vapes. So there will always be an opportunity for organised crime to take advantage of any loophole in any system, and they will find it.
Thank you. We've had an extensive discussion this morning about driving being impaired by cannabis, and some of the difficulties that, unlike alcohol, we don't have the nice 0.05, 0.08 that you do with alcohol. And suggestions around what we should be testing for is impairment rather than the presence of THC. Does the New South Wales Police have experience running impairment tests? What would an impairment test look like? And is it possible to do random impairment tests, or would that have to be a post-crash test?
We don't have a lot of experience in impairment tests. We make observations for driving under the influence offences, which are then presented to the court. But we're not experts in impairment. There would be significant training required to undertake that if that ever came to fruition. The issue of THC and impairment is it's very, as you indicated with alcohol, it's quite a simple threshold, and alcohol over certain limits will impact individuals. THC will impact upon individuals differently, leading to a greater level of impairment. Frequent users won't be as impacted, I would suggest, but medicinal cannabis at the moment is not exempt either. So we find people who detect for cannabis at roadside tests who claim that they're using it for medicinal use. We have fairly strong evidence that from our clinical pharmacologist that if someone is taking the levels of medicinal cannabis, then after 6 hours it won't reveal itself on a blood test or a saliva test on a roadside. So it's quite evident to us that people who, or some people who are subscribed or prescribed medicinal cannabis also use other drugs as well because it's cheaper, other forms of cannabis rather than just the medicinal cannabis that they are prescribed. So it's a really problematic area when you consider the number of fatalities. I think it's sitting about 16% of fatal crashes involve positive blood tests for THC, which is a significant number with a rising road toll. So our traffic and highway patrol take their responsibilities very seriously, and not just in not just with THC, but with some other drugs as well that we detect. I think it's 1 in 9 drivers they pull over test positive.
Wow. Okay. With respect to prosecutions for driving under the influence, are there? How do you prove that? What are the evidentiary issues in a driving under the influence or an impaired driving prosecution?
Physical observations of a person's appearance, Normally it's, and we charge, under certain conditions, we can't charge with we don't get a reading for a drink driving offence. We have to go with observations, and we look at being dishevelled, bloodshot eyes, slurring of speech, unsteady on their feet, those types of indicators, which are then put before a court. A court makes their decision as to whether that individual was under the influence of something or not. Impairment, certainly experienced drinkers, and I would suggest experienced cannabis users would be able to, because I've seen this with experienced drinkers who ultimately might reveal a very high reading on the breath analysis machine, but to be perfectly honest, you'd have to really scrutinise them to actually realise they'd been drinking at all. But they have a very high content in their blood alcohol, so it impacts upon people differently. But in relation to physical appearance, but what that impact has on their depth perception, their reaction time, and everything else is really undetermined. So impairment might show the physical signs, and we might be able to detect physical signs of impairment, but what that does to the individual in relation to their ability to drive, I don't think it's been tested.
We've had some evidence that, for example, medicinal cannabis users are responsible and could be responsible for deciding themselves if they were impaired. Is it your experience that people using alcohol and or drugs are the best judges of their own ability to drive?
I think experience would show that they're probably the worst people to make a self-assessment of their sobriety, whether it be from alcohol or cannabis.
Yeah. Thank you very much.
Deputy Commissioner, cannabis has been prohibited and legal in this state for nearly a century. Actually, we're up for 100 years this year. And has the prohibition led to reduced rates of cannabis use, or are cannabis use rates pretty much static, especially over the last few decades?
I don't think prohibition has reduced the level of consumption over the last 100 years, as you say, sir, but you wouldn't, if it was decriminalised or legalised, then you wouldn't know what the level of consumption might be. Might be at similar levels to smoking or whatever, I don't know.
It's possible it could just stay the same. It's readily available. It's an illicit drug that's readily available and pretty cheap. And is it possible that use rates could stay the same?
I'd be guessing, sir. I'm not too sure what the experiences are overseas in relation to the usage rates where they've legalised cannabis. But I think there's a certain deterrent effect for a proportion of society who won't engage in cannabis taking because of it being illegal, and I think that is a deterrent to a certain proportion of society.
What cost is there to the New South Wales Police Force's budget of enforcing cannabis laws? I mean, do you have a line item in your budget for the police who are out there detecting cannabis grows, arresting people, enforcing it, searching people? How much does it cost annually for the New South Wales Police to enforce our current cannabis laws?
We don't have a particular line item in relation to commodities like that. We do have a cannabis eradication team that sits within the Drug and Firearms Squad of State Crime Command, and their responsibility is to investigate major crops, whether they be hydroponic or in public parks. They do a regular, in the growing season up north, They visit commands with a helicopter and identify large-scale plantations of cannabis plants, sometimes unearthing over 10,000 plants in one crop, removing them and destroying them to try and reduce that supply. And they also look at hydroponic setups and target them as well. But that's just one squad of state crime, that's a particular unit of a squad of state crime that focuses specifically on cannabis. But
could you take that on? Sorry, sir. Could you take that on notice? Just the budget for just that unit. That would be interesting, I think, for the inquiry.
Yeah, we certainly can.
And do you think that we've heard evidence from other sources and the senior police that cannabis sometimes has been described as a startup business for organised crime. It's a relatively cheap and easy way to generate an illicit substance and an income. Are those major cannabis operations that you're investigating and eradicating, are they usually associated with other forms of organised crime, other drugs, arms, human trafficking, that sort of thing?
As I said earlier, the organised crime and the criminals involved in organised crime will take any opportunity to make a profit. And we've seen them move between different environments depending upon the profitability, whether it be cannabis, whether it be harder drugs, whether it be tobacco, where they can make the most profit for the least risk. Cannabis certainly has been seen as a precursor to potentially supply of more serious drugs. Once an individual crosses that threshold of criminality, which at the lower levels cannabis supply and production probably might be considered by some people in the community, it's not a long stretch to escalate for greater profitability within that environment if the opportunities are there for those criminals. So we don't see organised crime, whether it be organised criminal networks, whether it be outlaw motorcycle gangs, focusing on one particular commodity. Generally, they will take any opportunity to make a profit, depending upon what opportunities present themselves to them. So cannabis at the moment is certainly one of those, as are other illicit drugs, as is illicit tobacco, and as is illicit vapes at the moment as well. And we target criminal environments rather than commodities. We have a twofold process in relation to how we dismantle criminality, where they have environmental targeting, looking at the group itself, knowing and taking any opportunity to charge them with an offence, or looking at the commodity and following those commodities themselves. So in relation to cannabis and the work of the cannabis team at State Crime Command and the Cannabis Eradication Program, they're very much focused on the commodity. But in that, organised crime elements are pulling the strings on that.
Thank you, Deputy Commissioner. Ms. Fairman.
Thanks, Chair. Good afternoon, Deputy Commissioner. Why is it that so many people are still diverted or sent to court in terms of cannabis in New South Wales, despite us having the cannabis caution scheme obviously in place, as well as from last year, the early drug diversion initiative? Why is it that so many people are still going to court for cannabis possession and personal use?
It depends, I would suggest, on the circumstances of their detection by police. And obviously the conditions of the cannabis cautioning scheme were relaxed last February with the introduction of EDI to be aligned with that. There were certain preclusions prior to that in relation to the amounts. Now it doubled to, I think, 30 grams being allowed under that for a caution. The requirement for previously that if you had been convicted of a violence offence or a sexual offence or a serious drug offence, then you wouldn't be entitled to a cannabis cautioning scheme. You had to consent to the cannabis cautioning scheme. Those barriers to use of the scheme were removed at the introduction of EDI. But I go back to what I said before, it depends on the circumstances of an individual's detection by police. If they're being charged with a variety of offences, such as assault, such as break, enter and steal, such as stealing a vehicle, and they've got cannabis in their possession, they'll most likely be charged with the possession of that cannabis, even if it's a small amount, because it's in conjunction with a more serious offence, rather than charge them with a serious offence and then give them a caution for the cannabis possession. So I think some of the data is slightly skewed because we look at, when the statisticians look at it, they look at it as a single item, but I think we need to look more broadly, and I've spoken to our State Intel Command in relation to this after the last budget estimates, in relation to EDI and cannabis cautioning, that we need to look at what other offences they were charged at the time that they were charged with the cannabis possession.
So when you say we have to look at like other offences, is that with a view to ensuring that potentially because I think with EDI, I'm trying to find the data, which I'll have in a sec, but a significant proportion of people caught with cannabis were still diverted still sent to court and didn't receive the option of that phone call. So what that goes to show is that even that diversion scheme, there's either too many requirements in terms of too many, what is the word I'm looking for, the discretion in terms of the police doesn't seem to be working there, even with EDI. So you just said it was relaxed a bit after the cannabis cautioning scheme, but I think with the early drug diversion initiative, it's still not working.
No, I think at the time that EDI was introduced, so that it aligned, so the cannabis cautioning scheme aligned with that, the same set of criteria. The requirements for the cannabis cautioning scheme were made more broad, so more people could be captured by it, including the amounts being increased. The requirements previously, prior to I think the 24th of February last year, when the cannabis cautioning scheme was changed, if you had been convicted of a violence offence or a sexual offence or another drug offence previously, you were not entitled to a cannabis caution. Those restrictions have been removed. So you would anticipate seeing an increased use of the cannabis cautioning scheme. But if that's, I don't have the statistics in front of me, but if that's not the case, then I would suggest that possession of cannabis charges have been made in conjunction with the arrest of an individual for another offence as well. So it would not be a police practice to charge with 5 or 6 break, enter and steal matters, then caution someone for the possession of cannabis. You would charge them with that. Put them all charges before the court at the same time to reflect their true criminality.
I'll come back if there's more time for questions, Chair.
I don't think there will be.
Yeah, okay.
Okay. The government.
Thanks.
Mr. Lawrence.
Very much, Deputy Commissioner, for your time. I just wanted to ask some questions about stop and search and cannabis, and I suppose maybe other drugs as well. Has anything significant changed in the last 10 or 15 years in terms of the way that the police use stop and search powers in respect of cannabis?
No, sir. We our powers come from LEPRA, about our ability to have our reasonable suspicion in relation to someone and that threshold to search someone. If that reasonable suspicion is activated, then an individual can be searched, and then subject to whatever charges flow from what is found upon them, including cannabis.
Yeah. So how common is it in your experience, let's say, across the state for children to be stopped and searched solely on account of a suspicion of possession of a small quantity of drugs?
Would depend. I'm not aware of any data captured on that. I would suggest that it would depend on the circumstances of where that individual was located. They're coming out of a known drug house, a known supplier's house. That might cause, depending upon the individual officer's observations, a reasonable suspicion in their mind that they have the ability to search that individual. But it's not that. I don't think anywhere in the state of New South Wales do police on patrol go around looking specifically for to search individuals for cannabis use, unless there's circumstances that would dictate that. As I said, the circumstances of the environment they're in and who they're with and others, and observations made by police. So if they see a transaction, they're entitled to search. That would give them reasonable cause. But they don't patrol simply for the purpose of searching for cannabis.
So what about if young people are on suspect target management schemes or things of that nature? And I know the names of those has changed over the years. I'm not sure what the current one is. But are cannabis laws used then to stop and search young people who might be suspected of being at a higher risk of engaging in other crimes?
The suspect target management plan has been discontinued. We don't utilise that process anymore in relation to reducing crime. We now have a more holistic approach which looks at crime within a particular area. It's called prevention, disruption, response. So a command will be required to every month have a PDR meeting chaired by the commander of that command, PDR, prevention, disruption, response. Look at the crime problems within that particular command and come up with solutions for that particular area, because they are specific to individual commands. Yeah. All those documents are appropriately recorded. The commander is required to sign off on them. It's unusual, and at times individuals will be known by that command to be committing crime. That can come from a variety of sources, can come from a variety of informants within the community, can come from individuals' families, to be perfectly honest, that they are committing crime. So if that's the case, then reasonable cause of an officer working that command, their reasonable cause or their reasonable suspicion might be enlightened because of that knowledge, which may give them justification to search an individual, but who's in a potentially high crime area with the knowledge that they previously had and current intelligence of the crimes that have been committed in that area. And that's it could give them, as I said, reasonable suspicion to search someone.
So back in 2013, in my previous job as a lawyer, I did a case for a 17-year-old boy in Broken Hill, and he had an intellectual disability. He was an Aboriginal kid, and there was an issue in his case about the lawfulness of a search. He'd been found guilty in the Children's Court of the possession of a small quantity of cannabis, and there was an appeal where the lawfulness of the search that led to the seizure of that cannabis was the issue. And there was evidence in the case by way of COPS events that showed that in the previous 2.5 years, he'd been searched 26 times by police on the street and no drugs found on any of those 26 occasions. Just curious about your comment about whether you think that's an unusual situation.
If every circumstance is different, and we're working, we're now in an environment 12 years on, further on from that particular date. We don't have the suspect target management plan. I'm not at the moment. We don't engage in that practice. I'm not too sure what the circumstances of that particular search were that found the cannabis. If I had personally searched someone 26 times and failed to find anything, I would seriously doubt my ability to form a reasonable suspicion to search that individual again. But that's my personal perspective.
I should say I don't think it was the same officer every time, but it might have been, but I don't think it was. Yeah.
But the circumstances of that individual where they were frequenting might have led to some of those searches. I'm not sure. As I said, the individual matters if they were living or frequenting high crime areas, which were known, where offenders who were known to carry drugs were frequenting, and that might have led to the environment. As I said, we target, as an organisation, or state crime, certainly with environmental and commodity targeting. Local commands target areas where crime is committed.
Yeah, so the reason I raise it is it seems like, in terms of the public interest in searching people on account of the possession of cannabis to try to reduce that incidence of criminality occurring, if that was actually the purpose of those searches, i.e. To find cannabis, it would seem like an extraordinary use of resources. And it sort of suggests to me that that cannabis laws might be being used to pursue other police objectives in terms of other criminal offences that might be more serious. And I was just wondering if you think that is the case.
No, I don't, because I don't. I'm unaware of, unless an individual's or a known cannabis supplier is being surveilled by police, and we're pulling people over as they leave that premises to try and justify potentially a search warrant on those premises. I wouldn't suggest we would be ever targeting specifically for cannabis.
Yep. Okay.
In an individual, unless a drug dog. Well, drug dogs indicate drugs, not specifically cannabis. So, it's not a commodity that we specifically go searching for as a commodity on individuals. We look at it from the environment. We look at cannabis plantations. We look at hydroponic setups. We look at drug suppliers. We look at drug houses that supply cannabis, but most usually they supply other drugs as well. But we don't specifically search individuals with one intent in mind of possession of cannabis, unless the individual's well known to be always carrying cannabis.
So you're saying that you don't think that general duties police officers search people solely on account of a reasonable suspicion of possession of cannabis, that they somehow shy away from that if they form the requisite suspicion because they wouldn't consider that serious enough criminality? Is that what you're saying?
No, unless the circumstances dictate that an individual might be carrying cannabis, the reasonable suspicion doesn't surround the commodity. In most occasions, it surrounds behaviour of the individual.
Oh, sure, yeah.
And they could be, my point is that I would be very surprised unless the environment that individual's in and the circumstances that come under notice from police led police to specifically say that person could be carrying cannabis. It'd be more a general search looking for criminality based on suspicions and the area that they're in, the behaviour of the individual, the people they're frequenting with, and so on. That might lead to an individual officer's reasonable suspicion to search under LEPRA.
Yeah, okay. In terms of black market issues, and you talked about tobacco, obviously there's a black market in tobacco. I think we've had some evidence that might be explained by the high taxation of tobacco. We also had some evidence from the Crime Commission to the effect that there's not a black market in alcohol, except maybe for certain types of alcohol in cultural communities. But generally speaking, in Australia, there's not a black market in alcohol, which rather tends to suggest that legalisation of all products doesn't always lead to a black market. And in terms of cannabis, if legalisation was to be looked at, we've also had some evidence that the factors that might determine whether a black market does emerge would include the price of the cannabis and also how widespread its availability was. So, for example, if you couldn't access it in most of the state, then you're more likely to have a continuing black market. So apart from its provision and its price, I was just wondering if you can think of any other factors that might go towards determining whether, in the context of a legalised cannabis market, you would continue to have a black market, such as you do for tobacco.
If you look at specifically it as a commodity, and you can, whether it's cannabis or any other commodity, that it will, organised crime involvement will come down to their ability to make a profit out of it. So if there are opportunities for organised crime to make a profit out of cannabis, if it is decriminalised or legalised, then they will take advantage of that. As they have done with tobacco. Tobacco is driven largely by taxation and the price of legal cigarettes. But that's not the case with vapes. Vapes have been prohibited. Organised crime are taking advantage of that total prohibition of vapes to get them into the country and sell them. There's probably, vapes are prohibited, and then we're talking about legalising cannabis. And I'm not too sure where that sits in society's expectations. I'm not an expert on that, but certainly opportunities for organised crime will be taken if they're available to them. And if cannabis is decriminalised, I'm not too sure what that would look like in New South Wales. I'm not too sure what the price would be. I'm not too sure how that would be regulated, as it is in other countries to a certain degree still. So, I would be guessing as to what that looked like. But I will say that organised crime will take advantage of any opportunity to make a profit they can.
Yeah. Just one more question from me, and then I think Dr. Kane's got one. It always struck me as strange as a criminal lawyer, and noting in your evidence that you describe cannabis as a less serious drug than other drugs, it always struck me as strange that there's the same maximum penalty for possession of, let's say, a very, very small quantity of cannabis as there is for possession of a much larger quantity of methamphetamine, for example. If it's not such a quantity that it becomes deemed supply, then it's got that same maximum penalty of 2 years, irrespective of whether it's small cannabis or a larger quantity of meth. And same for the supply offence. It's the same maximum penalty for supply cannabis, whether deemed or otherwise, as it is for supply methamphetamine, unless you're getting into, obviously, commercial quantities or other aggravated quantities. I'm just wondering if you've got any thoughts on that the maximum penalty seems a bit odd for it to be the same in those respects for cannabis as it is for more serious drugs.
I haven't really turned my mind to it. Obviously, cannabis has its own cautioning scheme and has had since the year 2000, following the 1999 drug summit. The Early Diversion Drug Initiative commenced on the 29th of February last year for other small quantities of drugs. So they're more or less replicated in that environment with health interventions available, or the ability of the individual to seek that rather than under EDI certainly, rather than go to court. Obviously, a cannabis cautioning scheme, they get a caution, but they also entitled to health assistance if required, similar to EDI. In relation to the maximum penalties of the specific offences, ultimately, no matter what the penalty is in the statute, it's the discretion of the court as to what's awarded based on the circumstances. And there may be circumstances where possession of an amount of cannabis is more serious than the possession of an amount of some other drugs, such as cocaine or MDMA or methamphetamine. I'm not sure, but that's for the court to determine. But They are maximum penalties available based on the circumstances, but the courts certainly take a wide amount of things into consideration before they issue a sentence.
Thanks, Deputy Commissioner.
Dr. Kane.
I think I might put mine on supplementary.
Okay, all right. Well, thank you very much. Well, thank you very much, Deputy Commissioner. There were a couple of matters taken on notice. The Secretariat will be in contact with you in due course to get an answer to those. But thank you very much for the work you do on behalf of the people of New South Wales and for taking the time to appear at this hearing and assisting this inquiry. So thank you very much for your time this afternoon. We appreciate it.
Thank you, sir.
Thank you.
Everyone, do we have anything to deliberate on? No? Then I